Your leash here.
All right, good morning. We will call the meeting to order of the Health Insurance Affordability Task Force. It is Thursday, June 18th. The time is 8:31 and we'll start with roll call.
Good morning. This is for the Health Insurance Affordability Task Force for June 18th. Senator Crum. Senator Love. Representative Geringer.
Here.
Representative Pendergraft.
Here.
Mr. Boley. Director Johansson. Mr. Red. Mr. Red.
Here.
Commissioner Rude. Ms. Williams. Co-Chairman Larson. Chairman Nethercott. All are present, Madam Chairman.
All right, thank you. So do I have an echo too?
Yes.
Well, it's just the way it's going to be. Echo, I can't fix that. So we will go ahead and get started with our 8:35 a.m. Agenda item, which is the Wyoming Hospital Association. Mr. Boley? Okay, hopefully that fixes that.
Morning, Madam Chairman, committee members, Eric Boley with Wyoming Hospital Association, and I've asked my Vice President, Kelsey Prestisator, to set in and help. She's done a lot of the legwork on our presentation. Yesterday when we passed out our talking points, Representative Pendergraft asked me why we couldn't condense it to 4 pages. And I did say it was 4 pages just front and back. But we took the papers that you have and we've condensed them down into some slides that we wanted to share with you. And it is a good day. I drew an elk tag. The big game draws out and my son drew an elk tag, so we're excited about that. When I went home last night, I was a little, I had some mixed thoughts as I went home. Wondered if we even needed to do this because it sounded like the conclusion was that hospitals just charge too much and we need to lower their prices. But in reality, it's much more complex than that. And
Mr. Boley, I don't recall anyone saying that.
no, that's how I felt when I went home.
Just you.
Yeah. But the reality is that this is a really complex and an important issue. And I think having an understanding of how hospitals operate, what we're up against and what drives cost is super important. And so we've put together a presentation I think will answer a lot of those questions. So in the state, we have 30 hospitals, acute care hospitals with 1 psychiatric hospital and 1 rehab hospital. We also have a couple of physician-owned hospitals. We also have 35 nursing homes to serve about 580,000 people. And as we all know, we're a very rural, but really realistically a frontier state. A lot of times the nearest alternative.
Thank you, Madam Chairman. And it's interesting that you bring up the long-term care component, and I'm wondering why we acknowledge long-term care in this. Is it because some of our hospitals have attached long-term cares as part of their business model, and it's fair that you have it. I'm just trying to understand in this conversation why we acknowledge the number of long-term care.
Sure. Madam Chairman, Chairman Larson, we listed it for 2 reasons. One is, yes, some of our critical access hospitals do have nursing homes that are attached that feed into financial health. But secondly, as we take a look at healthcare and the cost of healthcare in our state, the continuum of care and having the ability to have patients treated in the right setting at the right time is also super important. And long-term care is very important in our state, especially as we start talking about the fact that we're housing patients that probably shouldn't be in our hospitals that drive to their overall costs that should be discharged and treated somewhere else. We won't spend much time on that. He just wanted.
No, it's fine. It just drew a question mark, Madam Chairman. I was just wanting to tie them together. Thank you.
Yep.
And so,
Thank-
Mr. Boley, just for clarification for the committee, I think Co-Chairman Larson is referencing the handout that's entitled Wyoming Hospital Association and the Wyoming Long-Term Care Association, and then there's the blue graphics. Is that what you're starting from?
That's, Madam Chairman, that's what we've created this slide deck from. And I think part of the reason we listed that is just because we also represent the nursing homes in the state.
So that's item number 13-4. And just so that you know, our meeting materials, we have 4 submissions from the Wyoming Hospital Association as part of our meeting materials. So we're starting with 13-4.
Okay, thanks. So we were asked to talk about hospital ownership and structures. And so there are 2 types of hospitals in our state. There's critical access hospitals and there are PPS hospitals. We touched a little bit on this yesterday. Yeah, okay, yep, I'll get to that. Critical access, a lot of times they're called CAUS, CAH, and PPS or prospective payment systems. As we discussed yesterday, our critical access hospitals, they're 25 beds or less. We have 20 of those in the state. And they have specific guidelines as far as they can't keep patients for more than an average of 96 hours as inpatients. But they receive cost-based reimbursement, and we'll talk a little bit about cost-based and cost reporting later. Prospective payment systems are our larger hospitals, larger than 25 beds. They are paid on a fee schedule. And so there's a kind of significant difference between those 2. We also provided, I don't know what number it is, I'm sorry, but we provided a spreadsheet and it's embedded in here that lists the different hospitals in our state. It lists where they're located. It lists their nonprofit or profit status, and it also lists the type of ownership that they are. And as you can see, we have realistically, we have 15 hospital districts, and we'll talk a little bit about the difference between a hospital district and also the difference between a county memorial hospital. But we have 15 hospital districts. We have several private hospitals in our state. Some are for-profit, some are nonprofit. And then we have, I believe we have 5 left, 5 of the memorial hospitals. The difference between a hospital district and a memorial hospital, they're both governmental sub-entities. But the county memorial hospitals are actually owned by the county. Their boards are appointed by the county commissioners. They do not have any taxing authority, but the county statutorily has the requirement to pay for the upkeep and maintenance of that building. We can talk about how that happens or if it happens in our state, but the answer is it really does not. In each of those memorial hospital settings, the counties have come up with different arrangements as far as whether or not they'll even give the hospitals any money for operations or to cover those expenses. And the difference there is our our hospital districts do have taxing authority. When the districts were passed, they were granted the authority to levy 3 mills. And then they also have the ability to go back to the voters and the difference there is our critical. I thought it was stereo. Oh, let's see. What was I talking about? Oh, no. Yeah, hospital districts. So when they're formed, the voters agree to 3 mills, up to 3 mills. And then they can actually go back for another up to 3 mills to be authorized. And it has to be done because the legislation's been passed recently, only on the general ballot. And it can be authorized for a period of time, but it goes back and is reauthorized by the voters. I think it's every 3 or 4 years.
Eric?
Yes, sir.
And so you've got a capacity of 6 then? It would be capped at 6 mills?
That's correct. Yes, Mr. Chairman.
And so on that sheet that you had, and I'd asked this earlier, did you ever figure out what the red 3s were for?
What's that?
On this
Yeah.
sheet,
Yes, sir.
some of the 3s are in red and some are in black.
Yeah, Mr. Chairman, We just
Magic.
should have made them all black. When this was updated last,
So that's fine.
we
I
just showed that we had added that information. I'm sorry.
No, that's fine. I just was wanting to just understand if that was sending a different message. Thank you.
Yep, great question. Finally, on this ownership, and the different, also one of the differences with a hospital district, they have an elected board, and which has its pros and cons also, but because they're authorized to tax their community, it makes sense to have representation from the community. And we can spend a lot of time on governance, but I don't think that's really what we're here about. Finally, and it's hard to see on this, but we've identified, we have 16 of those. Realistically, there's 27 acute care hospitals that do deliveries at this point. And they're distributed pretty evenly around the state. We also, one of the things that we've talked about is we've had 4 of our hospitals in the last 2 years, mainly our smaller ones, that have discontinued OB services for a bunch of different reasons, but a lot of it has to do with the financial pressure that service, which is sometimes a loss leader, has placed on their financials. You want to go through this one?
Yeah. And so as Eric mentioned, a handful of loss leaders that cause our hospitals to face financial hardship. OB is one of them, but emergency services is another. Mental health, behavioral health care is also another one. And so when we have these service lines that communities think are valuable and think that and really want in their community and want locally, that they don't want to have to travel to receive care, what ends up happening is our hospitals have to subsidize those unprofitable service lines with more profitable service lines like elective surgeries, for example, elective orthopedic surgeries. And going into that, there's fixed costs and variable costs that our hospitals have. And so that's a consideration when they're determining what service lines they're going to use and how they're going to subsidize those.
Can we get you to just slow down just a little bit?
Yes.
You're really
Sorry.
running through this.
Yes.
And then also, if you could direct us to, if you're referring to a handout or some of our meeting materials, if you could just direct us to, in the event you are referring to one, to which one you're referring to.
Yes. So for this specific conversation, I'm just referring to the slide on the screen. There may be some information in these meeting materials. Let me just check. So I don't believe that there's information on the specific costs in the handout that was provided yesterday. So we're purely just discussing this with you today. And for the variable costs, I think those are pretty self-explanatory. They're direct materials relating to individual patient care, things like medication, supplies that are used during the course of providing medical care in the ER and other services. But really what we want to drill down into is the fixed costs that our hospitals have that are spread over a low patient volume, which is really what drives a lot of the costs. And so when we talk about the buildings, property, salaries for physicians and other providers, nurses, equipment, MRI, CT machines, radiology. I know yesterday there was a conversation about the administrative costs that our hospitals have. We were able to pull Medicare cost reports for each of our hospitals in the state the last evening, and we were able to find that our hospitals average 18.3% of total hospital costs in Wyoming are directly tied to administrative costs based on the 2024 Medicare cost reports. These costs include HR services that are directly related to recruiting and retaining physicians and other medical providers, as well as other necessary staff to run the hospital. It also includes revenue cycle management personnel that handles all of the billing to various different insurers, handles contracting, also handles things like appeals, and basically chasing down payment.
You're doing great.
Fast again?
It's too fast. The court reporter is telling you to slow down. So since we don't have these meeting materials in front of us and we are trying to maybe track on screen, which we can't read, we're going to try to process these facts auditorily. And so you're going to need to slow down if you want us to take note of these facts that you took last night to go find and research for us. So go real slow so we can take notes and create our own handouts.
Sorry. So would you like me to start over in discussing the administrative costs?
I think just give us those stats one more time.
Okay, so our hospitals as a whole, as an aggregate, have an average of 18.3% of total costs attributable to administrative costs.
Push the button on my cell phone. And that aligns really well with what we seen yesterday in the Departments of Health spreadsheet.
Mhm.
It looked like it was about 18% across for administrative costs. So that aligns real well. Thank you.
Mhm. Yeah, absolutely. And so moving into the discussion on unprofitable service lines, how our
So,
hospitals are.
Madam Chairman, can we come back to, because in this document
Yes.
that you give us, we come down to the bottom of page 1 on regulatory compliance, which then I believe is attributable to your admin costs. If I read that document correctly, and it talks about the impact of federal and state mandates. And so I'm just curious if you could share with us some of the state mandates that have impacted your administrative costs.
Sure.
And then it also notes that administrative costs are estimated at 25 to 35% of all healthcare spending nationally. And does that fit in with Wyoming? And I think you're saying, no, it's more around 18%, right?
So total administrative costs in the state of Wyoming are around 18%. I do not have the figure handy for how much of that administrative cost per hospital is directly attributed to the regulatory burden that our hospitals have. I would be happy to compile that information.
No, I was just looking for examples. When you say these regulatory burdens contribute to our administrative costs, that's fair enough. But what are some of those state mandated things that are making those impacts?
Thank you, Chairman. One example that we've given during this most recent session is the price transparency bill that was passed, which we were supportive of because we want to be a good partner and we want to increase price transparency for consumers in the market that are visiting our hospitals. That mandate alone has caused our hospitals to have annual fees of $40,000, $50,000, even sometimes more, to be able to get those portions of their website up and running and keep them in compliance and make sure that all of the information is up to date. And so that's just one example of a state policy. We'll talk about federal policies and that have contributed more directly, I think, to the regulatory burden and financial costs for our hospitals. Things like the required use of electronic health record systems and how prohibitively expensive those can be, as well as meaningful use. Eric will talk about that a little bit, and that ties into the EHR conversation, electronic health record conversation.
Madam Chair.
Representative Love, or I'm sorry, Representative Geringer, sorry.
It's the other guy.
To my left.
Thank you, Madam Chair. Going back to, you mentioned the pricing transparency that we recently passed. I seem to recall in some of our conversations, aren't you required to have that transparency anyway from the federal level?
We are. That's
Okay,
correct.
so is that $40,000 to $50,000 really directly attributable to state mandates, or is that more federal and we just have some additional reporting requirements? I mean, I'm trying to get a feel here for what's really attributable to the state mandates.
Mr. Chairman, Madam Chairman, committee members, that's one example. And honestly, there won't be additional burden that will be put upon our folks to comply with what we passed last year, because we do have that federal. With that said, there has been legislation passed recently. Some of the abortion bills have caused us to spend a lot of time with attorneys, helping to consult our hospitals on how they can navigate those bills. If the 340B portion of the transparency bill would have passed last year, that would have been a state mandate, an unfunded state mandate that would have required all kinds of reporting to multiple agencies. A lot of what we face though is federal, unfortunately. But for every action, a counteraction. And so a lot of times when we pass state legislation, it does drive up costs because we've got to either change the way that we process and do our work, or we have to hire legal opinions to help make sure that we stay in compliance with those.
Co-Chairman?
But I want to refine that just a little bit, Mr. Boley, if I can, because all of us in whatever occupation, when a new law is passed, we have to look and see how it impacts us to some degree, but it may not mandate that I do anything. I just want to make sure that I'm in compliance, right?
Yeah.
And so as we're contemplating healthcare costs and medical costs, and if some of that is being put on you by mandate, meaning we're requiring you to do something that you've never had to do before, and as part of your business model that's impacting your bottom line, I think that those are the questions we're asking. Has there been any new mandated regulation that is in what examples of them are of that is there, so that we can contemplate how that fits in this whole scheme of things. So it's not necessarily that we pass new bills and that we have to have a legal conversation on what we have to do. That's kind of part of doing business. But if we insert something, I think you understand. And so I'm just trying to get that a little more refined to understand what maybe some of those mandates are that you're referring to.
Yeah. Madam Chairman, Mr. Chairman, definitely understand. And right off the top of our head, I think that was an example of what could have happened. Most of what we're going to be dealing with, I think that's part of the problem here, is a lot of what we need to deal with is on a federal level as opposed to a state level.
I'm just going to interject here, and I'm just going to ask, and so I think it's productive, do not feel the need to defend your costs, right? I think everyone in the room understands that healthcare costs, period, are expensive. We're all undergoing significant inflation. And so the cost of medical devices, the cost of equipment, the cost of workforce are all incredibly high for all of healthcare, all of every industry, right? And so there's no need to be overly defensive or to be concerned about that. What we're hoping to work together with you is to identify those costs that the state can partner with all healthcare providers, hospitals, and anyone else, that we may be able to reduce those costs in either an insignificant or a very significant way. So we would like to, or I'd like to ask you, I think generally we would like to ask you is to think about those particular buckets of costs that you experience in the hospital setting, that through innovative and creative ideas outside the box or in the box, that we can help reduce those costs uniquely in Wyoming. So with that, I'll turn to Representative Geringer.
Thank you, Madam Chair. And just to put a little bit finer point on both what each of the co-chairs was talking about, not just what new mandates or regulations have come down, but what is there existing? Is there anything existing, any red tape that we can cut to make things a little bit more efficient and make it a little bit easier to operate and translating into costs? And then overall, as the big picture, we are just what we're seeking here is any sort of solutions to help cut the cost of premiums, which, it comes somewhat from the cost of care, the cost of hospitals. That's so anything that we can do, we want those kinds of ideas, just to put the finer point on what they were each talking about.
So, Madam Chairman, Chairman Larson, we were given this list to prepare a presentation, and we actually submitted a document and we pulled it back because we do have some ideas, but we were told this was an information and a ground setting session. And so we have offered solutions that have come from the American Hospital Association that we're ready to adopt and accept. We also have some other ideas. So I will take your lead. We have a presentation that we were asked to prepare, but if we want to talk about solutions, I'll go either way.
Co-Chairman Larson, I know, worked very hard on setting this agenda. we'll keep with setting the stage for informing us as to why your solutions are right. So we'll keep this informational so you're prepared for today, consistent with the co-chairman's directives. But hopefully what you're doing is priming us for those solutions that we'll hear at the next meeting. But if you want to sprinkle them throughout your conversation, that would be probably a good idea. So time is always of the essence, as you know.
Right. We have a couple of things that we'll throw into our presentation, Madam Chair.
Over uncompensated care.
Yep. So you also have a handout that we prepared. We talk about cost reports and so one of the things we didn't cover when it comes to hospital licensure is for an acute care hospital to be licensed and operate, they have to conform and be certified by CMS or Centers for Medicare and Medicaid Services. Our physician-owned hospitals don't have that requirement. And so I think that in and of itself leads to some of the differences when we talk about fixed overhead costs, what it costs to deliver care in different settings. But with that said, our acute care hospitals in our state, they are required to accept Medicare and Medicaid. That's part of their operations. And with that brings the requirements of following all the federal rules. And we'll talk a little bit about EMTALA and some of the others a little bit later if you want to hear about it. But each year, at the end of the fiscal year, our hospitals prepare a cost report. And we've talked about that. I think Blue Cross Blue Shield referenced cost reports. I know the Department of Health did. But at the end of each year, as we talked about, critical access hospitals get paid cost-based reimbursement. PPS hospitals get paid on a physician or on a fee schedule, which is set by Medicare. And at the end of each year, there's a truing up. And so they go through a very extensive process. And I didn't share this with you. Some of you know I was a hospital business office manager, became a CFO, and spent 10 or 12 years preparing these cost reports. And they still confuse me because it's the federal government. We're here to help. So there are experts out there, but basically it's a matter of compiling all of the costs from each of the different cost centers, determining what was paid, and then what should have been paid or was overpaid. And at the end of each year, our hospitals either receive a cost report settlement or they end up paying the federal government back money. In most cases, our critical access hospitals may receive additional funding at the end of the year. But one of the components that goes into that cost reporting is an accounting of what the actual costs were for delivering uncompensated care. And so there is a graph or a handout that we prepared for you, and we talked about the uncompensated care amounts. We're seeing exponential growth, and we have a slide in here that shows from 2017 to the most recent settled cost report, which was fiscal year 2024, we've seen a 44% increase in uncompensated care. And it continues to ratchet up. There's actually 3 years worth in there. And last year was kind of an anomaly, fiscal year 2023. But as you can see, 22 and 24, we've averaged right around $140 to $145 million of cost for delivering uncompensated care. And this will feed into a further conversation we're going to have about financial health of our hospitals.
Thank you, Eric. What was that is an anomaly in 23. What drove that? Was there CARES Act money or something in there that?
Madam Chairman Larson, based on what I can see, it looks like we actually delivered, it was just less overall in total amounts. If you take a look at we'd have to go back and drill down into each cost report, but I'm not sure we delivered the same amount of care in that year.
But it seems to be consistent across all hospitals. That's you're probably right.
Yeah.
Madam Chairman. Thank you, Madam Chairman. Mr. Boley, I think with what you mentioned on uncompensated care, the Hospital Association, in fact, all of our hospitals deserve a lot of credit over the years for drilling down into what that means and how what the status is, how it's grown, how it's either grown or retracted over time. Curious, just for the edification of myself and the task force, help us understand how that uncompensated care manifests itself? Are those folks that come into the ER have to be served and there is no coverage, or it's not clear if they have coverage, certain services aren't covered? What leads to that, whether it's 100 million a year, 140 million a year, the figure you just mentioned? That is a significant issue here in Wyoming and around the country. But what are some examples of how that works? And I think what I'm really getting to is we can all understand when folks are uninsured, don't have coverage, but have an emergency, and then that emergency requires treatment, and maybe post-emergency, post-acute requires treatment, and much of that care is provided. Much of that care is required to be provided. But then there's other administrative issues where maybe there's an enrollment issue, a billing issue that it's not clear at the time if that insurance can pay. Give us some examples of how that works, especially for our small acute care hospitals.
Madam Chairman, Director Johansson, great questions. So there really are two components that go into the uncompensated care total. Part of it is underinsured or uninsured, and the other is just bad debt. And so we have seen an increase in the underinsured market where I think we were talking about it yesterday, the deductibles and the out-of-pocket maximums where they are insured, but they're considered underinsured if they don't have enough to cover their care. And then we're trying to collect those high $10,000 out-of-pocket maximums. And we've seen a lot of pressure that way. We also are seeing, I would say, an increased utilization of our emergency rooms in a lot of cases. And I think part of this is attributable to the lack of coverage we have for mental and behavioral health issues in our state. And I think it's one of the major cost drivers for a lot of our hospitals. There are examples just with Cheyenne Regional alone where they've housed patients and an adolescent in there for almost 100 days because they couldn't place them somewhere else, and that's not compensated. And so I think it's a myriad of different things. I would say that the Affordable Care Act, the way that it was passed, if it had been implemented, there may have been a completely different outcome from what happened, but the Affordable Care Act wasn't implemented the way that it was drafted. And so we've seen hodgepodge piecemeal, and it's really made the market difficult. If every state would have been required to do Medicaid expansion, we've seen that in expansion states, they've seen a 20 to 25% decline in their uncompensated care. If everyone had coverage as opposed to being uninsured, there'd be some payment. And so I'm not advocating for the ACA, but I think as we look at the exponential growth from 2017, I think it's because it just keeps falling apart, and it creates more and more challenges, not only for us, but for the insurers and for the consumers. That'd be my best explanation is we've got more underinsured or.
So I'd like to go back to the behavioral health component of it in Director Johansson, maybe just for the committee's help understanding that. So I understand. I would assume that these placements of adolescents in there are generally through the Title 25 process. If I'm wrong on that, and I took from what you said is that's uncompensated care, but I thought that we do have payments for that, the county for so many days, and then the Department of Health for that we'll get to. So if you could bring us up to that, Director Johansson, please, just to help us understand that. And then maybe that's not uncompensated, or it's not you don't get anything, but maybe it's not all you want. So Director Johansson, if I could, Madam Chairman.
Yeah, Director.
Madam Chairman, Co-Chairman Larson, thank you. I think it's a small but meaningful kind of microcosm of this issue when we talk about Title 25 to questions that were asked earlier about what are some of those state mandates, so to speak, that can drive costs. Title 25 is a good example, generally for adults, but you do have adolescents that go through that system, legal system as well. Chairman Larson, you're right. There's by statute, first 3 days of involuntary detention are the responsibility of the county to cover those costs. After 3 days or 72 hours, it's the Department of Health's responsibility. But I appreciate you bringing it up because it's a really good example of what I was kind of woefully trying to get at on where some of these costs can be borne. And I'll give a small example. Title 20, someone is emergently detained, either in the ER or by law enforcement and taken to the ER. County attorney files an emergency detention. That person starts going through the civil commitment process because of a psychiatric or mental health issue. Hospital treats, generally in the emergency department, sometimes in other ways. And we're waiting for placement at a psychiatric facility or at my state hospital in Evanston. And all the while the treatment's happening. Just assume for a second, which some of these clients have, that this particular Title 25 individual has insurance. The legislature used to have in the statute a provision that said the hospital should bill all public and private benefit sources, insurance sources, prior to billing the county or the state. Legislature about 10 years ago took out the person, meaning you can bill insurance, but levying copays and deductibles, you implicitly shouldn't really do that. And we've worked with a lot of hospitals who have those questions. This person has a $10,000 deductible. They're under a civil commitment. It's the county or the state's financial responsibility. And it's a tough issue because hospital could really go after, hey, we're going to charge this person after a civil commitment up to $10,000 for this week or two of care that happened. But we've worked with hospitals and there's not a great answer to say you should take that person's well-being into consideration, that after they go through a psychiatric commitment is the best thing to do to levy a large copay or a large deductible. And again, it's a small example. It's kind of a microcosm of this uncompensated care issue that isn't always about someone doesn't have insurance and receives emergency care at the hospital. There's these other issues where, a billing administrator or CFO is chasing payment that might not ever come. And so does that become bad debt? How can you write that off? We've seen that phenomenon happen a lot. And Title 25 certainly does not represent a large book of many of our hospitals, a large part of the book of business. But I think it's a really good example of when our hospitals, especially our small rural hospitals, are literally acting as an anchor or a safety net for that community where much of the emergency care starts and is provided. There's not always a great distinction between how they can be compensated. And Mr. Boley, I am absolutely not trying to put words in the association of the hospital's mouth. So any clarification, please educate me. But it's a really good example of some of the cost issues that hospitals deal with.
Agreed, Madam Chairman. Another example, as we drill down into this too, and when I guess what I would say is when we talk about insurance and insurance problems, we're talking about the industry as a whole. And yesterday we heard from Blue Cross Blue Shield, who we have had a very good relationship with for many years. But it's only a small percentage of our total market. And so another great example, I think, is what's really been happening. And I'll use the Medicare
Madam
Advantage as an example of that.
Senator Crum?
Yeah, just real quick before we move on, question would be the uncompensated care person shows up at the ER. So I know some of our hospital facilities have even in their hospital, a clinic, a walk-in clinic or a clinic. Is there anything that can be done to lower the cost? Because cost at the ER is very expensive. If we went to the clinic and got our cold treated, it would be much cheaper. Is there any procedure in place or a law that would present saying you really don't need to be here, you need to be here, please just walk 10 steps over here?
Madam Chairman, we can't necessarily do it that way, but there are examples in our state where they have an urgent care that's located close to the emergency room, and there's signage that if people read it might persuade them to go to the urgent care as opposed to the ER. Under EMTALA, which was passed in the 80s, I believe, emergency medical, I don't know what the acronym, it basically says that anybody that comes to our hospital has to be treated whether or not they have the ability to pay. And so when someone presents, which normally happens to our emergency room, they have to go through a whole screening process to determine what the corrective course of action is. And so if they come directly to the ER, we have to treat them there. And so we do have a couple of, I think we heard about it last week or maybe at the health care summit. I don't know. I've been to too many meetings, but there are some that have urgent care located directly adjacent to the ER that might have folks that would go to the urgent care as opposed.
I'd like to come back to the Title 25 question a little bit because it does involve the county, involves the county attorney. There's just the legal side. And to your point, the hospitals are really without, they just have to accept them if that's where, if there's no other place for them to go. Are there parts of the state that are impacted more by that than others? And I think more in volume. Do we have some counties that are titling 25 or titling people more than other counties, or is there an anomaly there that the hospitals have picked upon, I guess is my question.
Madam Chairman Larson, I might have to defer to the director, but I think we have certain counties that don't want to title them. And so we end up with patients that sit for a while because they don't want to have the hearings and they don't want to title them. I don't know if I know Natrona County takes a large number from all surrounding communities, and then they actually have the commitment hearing, I think right there, sometimes at WBI, depending, and have it done via video. I think a part of it also has to do with kind of the demographics of those communities. I mean, I know at times CRMC here is on diversion because they've got 25 beds that are occupied by folks that need placement other places, but I don't know. I don't know. The state might have a better idea of that.
Thank you, Madam Chairman. Frustrating answer, Co-Chairman Larson. It's a really mixed bag. You do have, higher volume counties, absolutely, mostly a factor of population, but also resources that are available in the community, where in the basin, for example, often the Title 25 interaction is more about holding an outpatient observation while additional treatment resources or inpatient resources are being located. Sometimes that's an agreement or a contract with another hospital like WBI, and sometimes it's just a waiting game for a bed to open up at the state hospital. It really just depends. And apologies if I brought us down a rabbit hole with Title 25, but again, I do think it's a good example, small example, but a meaningful one of when our hospitals act as a safety net. And I don't know if there's a solution there. There's certainly not a clear statutory solution of how you get all of those, costs or services reimbursed. It's an interesting interaction. And I think similarly with when Mr. Boley mentions, participating in Medicare and Medicaid, on the Medicare side, strictly federal, but my department through our licensing and survey office enforces all of those conditions of participation in Medicare. And that list, my goodness, we would spend an entire day just going through that list of requirements and regulations just to be able to serve Medicare clients and bill all kinds of things related to staffing ratios, allowable and non-allowable costs. So again, Title 25 was more meant as an example of here's a requirement the state has. Everybody wants to do the right thing to help someone in an absolute crisis. But the way to get those costs recouped or paid and to whom is a difficult matter. And often our hospitals are left holding and treating patients with some uncertainty around the compensation that might come.
So to put a finer point on the Title 25 piece, having studied it for years, and wanting to keep it limited in scope to what Director Johansson identified as a potential action item, where he specifically noted that 10 years ago, the legislature made a mistake. Yes, the legislature made a mistake and eliminated the ability, it sounds like, for the hospitals or the counties to pursue in a subrogation type matter, the private health insurance that a individual may have. And so I think there's also confusion between what Mr. Boley said and what the director was presented to ask, which is whether or not the emergency detention is done by an act of the government, i.e. you called the police because somebody is suicidal or homicidal, or you brought in a family member because they were exhibiting the same things, a voluntary versus an involuntary commitment. And so no doubt whether or not health insurance covers that mental health treatment is a big question mark. But whether or not that involuntary treatment is covered by the county or the private insurance and how that works. So if we want to go back and look at that repeal of whatever that provision was, allowing for the pursuit of private health insurance or other types of payments concerning the state's obligation to have an emergency detention statute like all other 50 states do. So it's not one of those state mandates that we could repeal, but how we allow for the compensation associated with that action to take place. The co-chairman and I will discuss having that action that the legislature took 10 years ago on our next agenda for the concept of Title 25 to be narrowly reviewed, associated with how to recover costs to our hospitals or other healthcare providers when either a voluntary or an involuntary commitment occurs. With that, I strongly suggest we move away from Title 25, just due to the complexity of that particular issue, and allow Mr. Boley to get back to what he hoped to tell us today.
Madam Chair,
Senator Crum.
just real quick, I may be the only person in the room, but you threw out an acronym. I believe it was WPI. WBI, what is that?
Madam Chairman, Senator Crum, it's Wyoming Behavioral Institute. It's the only psychiatric
Okay.
hospital in the state,
Okay,
other than
no,
the state.
Thank you.
But just to maybe, this has nothing to do with Title 25. I would say in our state, we have seen a tremendous uptick in dealing with mental and behavioral health issues, whether it's Title 25, insured, uninsured. We see a tremendous amount of recidivism in our emergency rooms because that's where they go to get treatment. I do think it's a cost driver in our state, and we've seen other states. And yesterday we heard we were compared to other states, but I would tell you that Alaska is invested heavily in that population that needs that type of help. I think it's one of the areas that our state is truly underserved, and I think if we found correct treatment, it could help drive down the overall cost of healthcare. One other example that I was trying to talk about also has to do with, and as we talk about administrative burden, but what I was saying is that while Medicare Advantage is a great example of another problem that we're facing that is driving our uncompensated care, as are other prior authorization problems. And so we have found that the insurance companies, Uniteds of the world, use AI and use algorithms. They deny 50% of the prior authorizations right up front. Of those 50%, when they're appealed, almost 80% of those are overturned. But what we are finding is as prior authorizations are not authorized, or they're denied after the fact, after delivering care, the patient sometimes won't go back and appeal that and won't work on it. So one, it adds additional administrative burden on the hospitals to chase down that payment and try to work through it. And a lot of times it just goes uncompensated. And so, and as I was saying, when we talk about insurance, we're talking about insurance industry. We're not talking about our local partners. We've actually worked really closely with Blue Cross Blue Shield to address some of these issues. We could get you more examples if you want.
Mr. Red?
Madam Chairman, Mr. Boley, thank you for providing the uncompensated care numbers. And I see now we're moving on to operating margin percentages as a percentage. And one of the questions I had was how the percentages are weighted against the overall profit in the hospital system through Wyoming, because I don't think that this graph would indicate what the overall profit margin would be in the entire state of Wyoming. As an example, on the very left of that graph, you see a 22% operating loss. And on the very right, you see a 24% operating margin. So is the margin on the very right the same in a dollar figure as the operating margin in the very left as a negative dollar margin? And I think part of the reason I asked that is that for the uncompensated care figures that you shared, which are very large, are those net uncompensated care figures, meaning you're taking into account subsidies that you receive for the uncompensated care that the hospitals realize?
Madam Chairman,
Mr.
Mr.
Boley?
Red, these are a percentage of their overall, so it's not dollars to dollars. It could be one of our larger hospitals and smaller hospitals, so it's just based off of their total operations for that year. As far as the uncompensated care figure is concerned, one thing that we can share is, and we have another slide that shows margins with or without the governmental subsidies, and you can see there is an increase or there is a benefit there, but we still show that. What we do show and what we could share, we did a study not too long ago. It isn't encapsulated in this presentation, but the mill levies in particular normally don't make up the total amount of uncompensated care for each of those hospitals. And in some cases, like our memorial hospitals, they don't receive any governmental funding to help offset that. We have one of our memorial hospitals that actually receives $300,000 a year from the county to help offset $1 million loss on Title 25.
Thank you, Mr. Boley. Just as a follow-up, Madam Chairman. So in looking at DSH payments, those come from Medicaid and Medicare. Is that a correct statement? DSH payments? Is that something you're familiar with?
Madam Chairman, you talking about dish payments, Mr. Red?
I'm talking about disproportionate share
Yeah.
hospital payments that hospitals receive for uncompensated care. And also, you had mentioned before 340B reporting was part of transparency, a transparency bill that was passed. I think 340B payments are also considered subsidies, potentially for uncompensated care. And then there's other supplemental payments, whether we're talking about mill levies or other types of supplemental payments that hospitals receive in addition to the uncompensated care. So you have a gross uncompensated care amount that it sounds like it's $141 million. But I guess the question is what would the net be after receiving subsidies? Because when we talk about our premiums at Blue Cross Blue Shield of Wyoming and what the cost of those premiums are, we're taking into account the subsidies that we receive from the federal government too. So we're not saying that our premium is, this sky high number because we know that it's taken care of by the subsidies that we receive from the federal government. So I guess my question is when we're talking about uncompensated care, are we netting that down to the actual amount of uncompensated care after subsidies are received?
Madam Chairman, Mr. Red, the dish payments, disproportionate share. So that's a payment that only a handful of our hospitals receive. They have to have a certain percentage of their payer mix. I think it's 10%, might be 9%. That's Medicaid, and they receive a small supplemental payment. I think in our state it amounts to less than $600,000 for the few hospitals that actually qualify. As far as the uncompensated care, that's the actual cost for delivering that care to those patients. When we talk about our profit margins, that does factor in everything that you've just suggested as far as the different, and I actually didn't, the 340B did not pass. It was part of a bill that did not pass, but the transparency bill did.
Mr. Boley, sorry, just as a follow-up, Madam Chairman, I understand that the 340B transparency bill wasn't passed, but the 340B program provides payments or supplements to hospitals to offset costs. Yeah, so when I brought up 340B in that context, I agree with you that it wasn't passed. But what that bill might have done would be to add transparency to how much hospitals receive from the 340B program, correct?
Madam Chairman, there are a whole lot of things that bill would have done. Yeah.
No, thank you, Madam Chairman.
You want to wait?
So, Madam Chair, Chairman, as we talk about the uncompensated care totals, we also need to address the underpayment that is paramount to why our hospitals are financially struggling. And we talked about this at length in some of the earlier labor committee meetings, but also I think it was addressed briefly yesterday as well. Medicare and Medicaid both are habitual underpayers. And I know that you did not receive this PowerPoint ahead of time, but if you are able to see on the screen, which you likely are not, we'll send this PowerPoint over after the meeting today. Oh, you do have it. Okay.
Our LSO staff made copies for us as the meeting was going and handed them out. So thank you.
Thank you very much. You can see that the Medicaid operating margin, when we're only considering payments from those specific payers as well as Medicare, it's not enough. It does not cover any of the costs. And so what happens is Medicare paying around 73 cents on the dollar at the most recent figures that we have. Medicaid also does not pay what hospitals' costs are. What happens is we end up shifting those costs to commercial insurers. Blue Cross spoke at length about that yesterday on how they do take the higher brunt of the hospital costs. And so when we talk about uncompensated care as a percentage of revenue, Wyoming is also 2% higher than the national average when we talk about that burden that's placed on our hospitals here. And so when we look at our payer mix from hospitals, why it's so important that we discuss the underpayment from Medicare is because for the majority of our hospitals, Medicare makes up 48% of their payer mix on average across the state. And so when we say that a lot of these issues are directly tied to the federal government, this is what we're talking about. Addressing state solutions for commercial insurance in the state or even Medicaid will solve a part of the problem, but really we need to have that increased reimbursement from Medicare. This is also a large reason why a number of our hospitals in the state have recently converted to critical access hospital status and away from prospective payment systems. Because, as Eric mentioned earlier, the reimbursement from Medicare when you're a critical access hospital is 101% of your cost, which I think went down to 99% because of sequestration. So that should give some color to kind of the landscape that our hospitals are facing when they're discussing their payer mix and why there might not be as many state solutions for this particular part of the problem that we're talking about.
Madam Chairman, I would just share with you, I've been in the industry about 30 years in the state, and this graph would almost be flipped 30 years ago. Our payer mixes used to be much higher on the commercial side, and we had much less on the governmental side. But if you add the other governmental payers, which is VA, Medicaid in there, we're close, and then a little bit of self-pay. It's almost transposed from what it used to be, which has really affected the market in general. And as I think more about it, I think it also might be driving part of the reason that we're seeing more of the uncompensated care, because you've got more reliance on underpayments from governmental entities.
I'd like to go back to the Medicaid and Medicare conversation. And I think the one that we have the most control over as legislature is the reimbursement rate for Medicaid, and at what level we reimburse for particular service. My question is, if the legislature had the appetite to increase allowable reimbursement at a higher rate, then do we see would there be a direct relationship to the amount being, it may not be dollar for dollar, but percentage wise overall reduction in the impact to health insurance within that model? And my question I'm trying to get at is you indicated that because we don't get reimbursed at a higher rate, we make that up by charging the insurance companies or for those services more. So if we were trying to reduce that impact, you would do it by increasing the reimbursable rates for Medicaid. So if we actually done that, would we see that happen?
Mr. Bully?
Madam Chairman, Chairman Larson, I think it's a great question. And I could see how there should be a correlation to that. I think we'd have to study it out a little bit. I mean, as you take a look at profit margins and things, I would hope that we would see that. I mean, and it could be incremental. And there is that ability. I think we have limits though on how far Medicaid can be increased. I think Medicare's the limit. You can't, I think, but and what we are grateful for is what was passed during the last session where our critical access hospitals that deliver OB services get 101% cost coverage on all inpatient services, not just on OB. And it'll be interesting to see what that impact has as we roll that out starting next month. But I would hope there'd be a correlation. I think it'd be worth looking at for sure.
Madam Chair.
We'll go to Representative Pendergraft.
Thank you, Madam Chair. I heard a number 70 cents on the dollar for Medicare. What's the number for Medicaid?
Madam Chairman, Representative Pendergraft, I think it's around 40 something cents to the dollar. Does that sound about right? Yeah, 40 to 50 cents on the dollar.
Senator Crum.
Yeah, just looking at this chart, just some clarifications and some questions. It looks like to me about 63% of our total payer mix is really government controlled. And so approximately 2/3, 1/3, 1/3 is kind of carrying the boat for 2/3 is the kind of way it looks. I don't know if that's the correct statement or not, but appears to be.
Yeah, Madam Chairman, Senator Crum, I mean, when we talk about cost shifting, and I think that's part of what's happened with the insurance market, right? Is that it used to be that cost shifting wasn't nearly such a heavy burden because we had more insured and we were not trying to supplement or take care of the underpayment from all the governmental payers. And I really think that's one of the big challenges our state is facing right now is the silver tsunami that we're facing, where we have the second oldest or first oldest demographically population in the state. We're dealing with older, sicker people now that are underinsured.
Thank you. And then does the self-pay number, the 6%, does that include the co-pays, the deductibles that people, they've got insurance, but they may have a $500, let's say, co-pay or something. Where's that 500? Does that go into the commercial bucket? Let's say if it was a commercial payer, or is it going, does that 500 shift over to the self-pay bucket?
Mr. Bowley.
I'm looking at my right-hand person here that put that together. She says that is included in there, the co-pays.
It's in the self-pay. Co-pays are in self-pay.
Yep.
Okay, thank you. And then when we look at this chart, I think it's already been said, but Medicaid, 8% is really, we have some direct effect on the state on about 8% of this market. Now we can do other things with maybe some regulations and other things, but as far as direct payment or whatever into the system, the state has about 8% of that pie that we can really affect. Thank you, Madam Chair. Mr. Bolden.
Director Johansson, just to help us understand the system, when Medicare, which reimburses at a higher rate, when we reimburse at 100%, that's allowable. That's where they set the limit. If we exceed 100%, 101, 102, that 1 or 2% then is state general funds.
Madam Chairman, Co-Chairman Larson, generally speaking, yes, just to briefly clarify. So Medicare, the fully federal program that insures generally people over 65, fully federal, with a few exceptions, we have very little control over Medicare policy. On Medicaid, obviously state-federal partnership, we have far more control in partnership with the legislature on not only what we cover, but the rates that we pay. Generally speaking, there's something that we like to affectionately refer to as the upper payment limit, which the federal government says Medicaid for these services or these types of procedures, in order to generate federal matching dollars in that state partnership, here's the rate that you can set at a ceiling, which is the upper payment limit generally tied to Medicare reimbursement, what the Medicare program would have reimbursed for the same service. Co-Chairman Larson, it gets a little bit more complicated because the state does have some flexibility to pay over that Medicare limit or 100% of cost, as we say. But if you exceed that in aggregate greatly in a service line or in a provider type, then often that needs to be general fund, state funded only programming and financing that covers that additional gap.
Madam Chairman, through you. Good morning, Mr. Boley. Just a question as we talk about Medicare reimbursement rates and where the shortfall is coming from. You know, we're talking 70 cents on the dollar. Is that because of our unique demographic and the cost of our overall healthcare because of the number of people and this, how vast our country is and how far we are to services? And or is that just a nationwide? So my thought is are we being reimbursed at a national rate, but Wyoming being unique in its shallow population, is that causing this difference in the reimbursement?
Madam Chairman, Senator Love, so it's nothing simple, right? But what I would say is our fee schedule, the fee schedule that we're paid off of by Medicare is universal. There are some caveats in the way that our hospitals are reimbursed, and Mr. Red referred to the DISH or the disproportionate share payment. There are other factors that weigh into what we get reimbursed, and some of those. And if you talk to Charlie Scott, he'll bend your ear on these. But some of our hospitals are considered sole community provider status, and they receive additional federal funding because they're the safety net. That's factored in, still factored into where we land. There is also, and I'm getting way in the weeds, but it's called area wage index, and it has to do with the average wage of your state. And there are multipliers that go into that area wage index, and we get hosed in that deal. You'll see much higher amounts go to states like California, New York, other states. And in particular, we really get hurt because our average wage in our state is greatly influenced by Teton County, which also has a huge influence and input on what our federal match is for our Medicaid rate. But there are a lot of factors that go into what each hospital in our state is reimbursed based on some of those other programs that factor into overall payment. But the actual fee schedule itself is set, if that makes sense. So you have a base fee schedule, and then you have add-ons on what you get paid or deducted based on some of those other factors, and that varies by state and by facility.
Madam Chairman, through you. So would it be possible to get us a breakdown and explanation of that shortfall of repayment? I know it comes at a fairly complicated process, it sounds like. So if we can look through that process and see if there are solutions inside of that repayment issue, maybe there are things we can do to help with that in the future.
I suspect that the director can also help that. Department of Health.
Well, Madam Chairman, I was Chairman Larson and I had a conversation about future meetings, and if the committee really wants to do it, we could potentially bring in an expert that could talk about that as well. Or we can try and get something in writing. It's not super simple, but yeah, we can come up with something. We'll take your direction on that.
I guess to me, the question really comes down to whether or not Medicaid or Medicare payments and whether or not those are causing some uncompensated care costs to occur. I need some compelling data regarding whether or not that is causing an increase in overall healthcare costs. Because when I go back and I look at that line, premium reimbursements for Medicare and Medicaid have increased over time, throughout that 50-year span. And I haven't seen any dips in that, even minor dips in the costs of healthcare. And so again, going with the premise, if it's true, that premiums follow costs, and Medicare, Medicaid, are same concept as premiums, right? But if costs are increasing, we're just always going to be chasing that. And so we're not actually solving the underlying issue. We're just adding to the inflationary costs and we're just kind of band-aiding the situation. But it's not reducing our overall costs by addressing uncompensated care through inadequate Medicaid, Medicare reimbursements, which is a situation, no doubt. And I don't want to ignore that, but I'm not sure we are reducing our healthcare costs overall. So the Medicare and Medicaid reimbursements will always be inadequate. But how do we reduce that burden on our healthcare system? And that's by reducing healthcare costs. That's my belief. And so I don't know if we're solving any issues other than how much more should we increase our Medicaid rates in Wyoming and providing another appropriation, which is the only answer that's going to be achieved with this exercise, which may be a prudent exercise, but not one that's going to reduce our health insurance affordability concerns for the people of Wyoming. Mr. Boley?
Madam Chairman.
Madam Chairman, just a thought on your thought process. If I understand what you said earlier correctly, that uncompensated portion of Medicare, Medicaid is actually being shifted on to insurance payers. And that's what's driving the cost of the insured payees portion higher and creating the discrepancy that lives inside of insurance costs.
That's what I've heard for quite some time. I'd like to see data directly on that point. So how much uncompensated care a hospital is experiencing as a result of inadequate Medicare and Medicaid reimbursements, and then how that hospital is overcharging the minority of the hospital's customers who are the private pay self-insured, and really see where that inadequacy or how that's being overcompensated. I'd like to see that data and to see that correlation. That's because that's a allegation that has been made, and all of the experts are nodding their heads, but I'd like to see it. Because I'm not seeing that statistic on the PowerPoint graph. Representative Pendergraph?
Thank you, Madam Chair. All the talk of data. Director Johansson, I found invaluable over the last year, the health stat 2024. Is that still the most recent addition, or have we put a new final report out that is newer than that?
Madam Chairman, Representative Pendergraft, health stat for everyone's awareness is our internal performance management system and report that we do on all of our programs in the department. The most recent was what we sent to the legislature this last February. I would also mention that years ago, we were directed by the legislature to develop a methodology and a report for provider financials, hospitals, nursing homes, but then others who don't have cost reports with Medicare. We used Form 990 data for nonprofit mental health centers, senior centers, et cetera. The data is a bit lagged because there's data lag on these types of cost reports and financials, but happy to share that with the committee. It's a breakdown of financials in aggregate, total margin, days cash on hand for different types of providers. It's a lengthy report, but happy to share that with the committee.
Madam Chair.
Senator Crum?
Thank you. Madam Chair, question would be one is I would really like to see, we talk about Title 25, and if somebody goes in the hospital, we have to treat them I think we said in the emergency room. I'd really like to see what that language said. Does it say, do we have to treat them in the emergency room, or do we have to treat them somewhere? The emergency room being the highest cost of the whole situation. So if there was a way to put a system in that maybe said, okay, you walked in the door, we're going to treat you, we're going to take care of you, but we may send you here versus here. And number two is I would really like to look into this idea of co-pays and where they're getting paid, because I know some hospitals in the state take that co-pay piece and put it under commercial, so self-pay is I don't want to use the term, but I'm going to use the term self-pay almost means no pay in many cases. And I'd really like to know where that's falling, because I imagine co-pays get paid quite a bit and other self-pay doesn't get paid. So I'd like to see a breakdown on that too, Madam Chair.
Dr. Johansson, Title 25.
Madam
Thank you.
Chairman, I feel like you might banish me from this committee for discussing Title 25 a few minutes ago, so apologies. But Senator Crum, no, there's no specificity on the level of care on the provider side in Title 25 statute. It's more about the legal process of detaining folks, and often just naturally that involves emergency departments and then later other types of providers. But happy to follow up on your second question or defer to the Hospital Association or our hospitals on breakdowns of that type of uncompensated care when you see it. I'd have to look at what we have and think about it a little bit more.
Representative Pendergraph.
Thank you, Madam Chair. Question is for you, Mr. Boley. If you're a hospital and somebody walks into your emergency room and you know that you have to serve them, is there any motivation from your perspective, because you know you're going to bill at the highest rate you can, is there a motivation then to refer someone to an urgent care clinic or something aside from that, other than maybe you look at somebody and say, well, they're obviously not going to pay?
Madam Chairman,
Mr. Boley?
Representative Pendergraft, I have to push back on that. We are not going to charge them the most we can charge them. We're going to charge them according to the treatment that we provide them, and that's strictly regulated. I think once we stabilize them and get them to a point where we know that their life isn't in danger, there is the opportunity to refer them somewhere else. But when they first present to the ER, we're required to assess and stabilize, and then we can come up with a course of action as to where they should be treated.
Yeah, and I think some of that has to do with what Mr. Boley referenced as EMTALA, which is the Emergency Medical Treatment and Labor Act, but I have a computer in front of me. I think Ms. Bush from the Medical Society will speak to that with a little more detail later. But it's that law essentially, over broad definition, requires an emergency room to treat the patient and not refer them to another provider without stabilizing them. Senator Crum. Any other questions from the committee before we let Mr. Boley keep on going with the presentation?
We can.
If you
quit
remember
want,
what it
Madam
was.
We're good if you want us to stop too.
Okay. So I want to go back to this concept of uncompensated care resulting from underpayments from Medicare and Medicaid. And so do you think if Medicaid reimbursements were increased, that healthcare costs would go down?
Madam Chairman, I can't guarantee that would happen. No.
Thank you. With that, Senator Love would like to do a rebuttal. Senator Love.
Not necessarily a rebuttal, but Mr. Red, if that same scenario happened, do you think that insurance premiums would go down?
Mr. Red.
Mr. Love, thank you, or Senator Love, excuse me, thank you, Madam Chairman. I think that's an interesting question. I think that what we've seen is there has been medical inflation year over year. And, without dancing around the issue, we've seen this hospital operating margin percentage graph. Blue Cross Blue Shield of Wyoming mentioned that we had a 4% operating loss in 2025. So I think what I'm curious about is, what is the overall net profit margin in the state of Wyoming for all hospitals combined? Do we know that?
Madam Chairman, we could get that for you, Mr. Ed, but we don't have it today. We weren't asked to
Okay.
prepare that.
I think the reason I asked that question is that if costs continue to rise, it really won't matter if someone pays more because we will all pay more.
We're just chasing it. Okay,
Madam Chairman,
yeah, Mr. Boley, go ahead.
one comment you made though, about Medicare itself, like Medicare, as we talk about Medicare payments, they don't increase every year. We
Right.
actually see decreases. And usually the increases that we do see are supposed to keep pace with inflation. Medicaid is another great example. We fixed a couple of problems in the last legislative sessions. Our nursing homes had their rates frozen for 12 years. Our EMS services had their rates frozen for longer than that. And we fixed that with some of what was just passed. But the fact of the matter is that we continue to see downward pressure on the government payers because it's becoming insolvent because they're facing the same issues we are, an aging population in a country in a plan that was designed and implemented and it's not being administered properly. I think the other thing that I would say is I wouldn't say that, I would just say that the way that the healthcare system works now, the relationship between government payers, self-payers, and insurance payers, I wouldn't say that we are doing anything nefarious. I think what we are doing is we're charging what's necessary to keep the doors open. And I think Chairman Larson has a funny saying, but we have hospitals in a lot of our small communities who expect us to do face transplants and what's the other one? Anyway, brain surgery when they want it. And some of the stuff that I think that is important, we haven't covered in our conversation, but we need to be able to build economies of scale, and we don't have bargaining power. We don't have economies of scale to drive down those costs. So we have high fixed costs. And to deliver that care, we've got to be able to cover those costs. And so even if we take a look at the very bare minimums, which is ER, some people feel OB in every community is critical, stroke and trauma, some of those things, which we think is super, super important. In a lot of cases, we're not able to cover those costs based off of if we were paid at the government level. And that is where the relationship with our commercial insurers comes in. We're a unique state, and we can debate that till the end of the earth, but we're more frontier than we are rural. We don't have investments in certain areas that other states do that we're compared to. And I guess at some point, the communities are going to have to decide whether or not those services are necessary right there at home or whether they want to travel for them. But when I take a look at our state, and when I consider that we almost lost the hospital in Rollins, and I've spent the last 2 years making sure that it still is open, what is our state to do if we have 200 miles of interstate that's not covered with even basic services? And so there is a sweet spot. How we find that sweet spot is an interesting exercise. And I think unfortunately the whole healthcare system itself is morphed and has turned into what it is right now. And I'm not sure that the federal government's got the appetite to go back and blow the whole thing up and come up with something that works. But while we are still required to adhere and work with Medicare and Medicaid and follow their rules and regulations and their conditions of participation. And a great example is that they can use those conditions of participation against us. During the pandemic, we were required to have all of our employees immunized and wear masks, or else they would stop paying us and they would not allow us to admit patients, which is fast backwards from what we needed to do during the pandemic. But they carry a big stick. And so I can't tell you that this is a perfect healthcare system. I can't tell you there's a perfect one in the country or in the United States either, because I've dealt with socialized medicine in Europe, and it's not what everybody says it is. It's a heavy lift, but I just think we need to realize that this is something that's morphed and grown over time. We are in a tough spot. Healthcare is expensive in our state.
I'm going to go to Ms. Williams. Ms. Williams?
Madam Chairman, I just wanted to make a comment for consideration. I think that what's interesting as far as the dog chasing the tail is the volume, which you said it stated in the beginning that a surgeon in Colorado may charge $3,500, whereas a surgeon in Cheyenne is going to charge $16,000. So without the volume, we're going to really have to think outside the box. I don't know how it plays into with attracting and retaining providers. I feel pretty lucky that I live in the big city. I don't know for sure whether it's Riverton, I don't know who to pick on, but I don't have to drive 25 miles to see a radiologist. And so I'm trying to keep in mind that rural frontier nature. One of the things I find interesting and can really understand and am compelled to feel for is the requirement of overhead and operation, because the hospital is required to do all the things. So if I'm a radiology company, that's all I do is radiology. And so I'm not suggesting it's a genuine solution, but for employees group insurance, we don't have the medical expertise. We don't have a medical director or somebody who knows in our office how to adjudicate claims clinically and properly. We outsource it. And so even with the administrative fee that we pay for that outsourcing, we're still only taking 4 cents out of every dollar to run the program. If we had all of that in-house, it would be vastly more expensive. So I'm just pointing out that the volume seems to be and we can't fix volume, right?
Well,
And those folks maybe with volume can withstand the lower reimbursement rates because they've got, they're like cows. We're just going through the system, right? We don't have enough butts in seats. So just a comment.
Thank you, Ms. Williams. Co-Chairman Larson.
Thank you. Thank you, Madam Chairman. In 2 points, one to Ms. Williams' point is in my community, where there's a lot of angst on hospital delivery and care, really centered around OB, where it seemed unreasonable to the citizens of that area that you'd have to drive 30 miles for OB care to have a baby in the hospital. And I was always struck by that because I had 2 children living in Denver, each having to drive more than around 45 minutes to have a baby in a large metropolitan area. But we have these expectations that really put pressure on hospitals to provide these services that sometimes I think maybe a little unreasonable. Director Boley, in this handout, which is really nice, thank you. You talked about medical inflation, and we talked about volume and things. When you come down to pharmaceuticals, and it could apply to other durable goods as well, it says hospitals lack large system purchasing power because we have memorial, county, private, everybody's business model is different. And as this committee looks at ideas on what the state could do to help with that, and this is my idea, but I'm going to throw it out here. If the state then were to purchase the drugs for all of the hospitals, those high volume drugs, and got that greater volume discount and then distributed them out to the hospitals, does that have value? And it could be on a number of those types of issues. And then it talks about storage costs, but the state could, in the similar situation we look at, or the example is the liquor division. We store all the liquors, we distribute it out, we buy it. But if we had a model for some of that, do you think there's interest within that hospital community to take advantage of that kind of purchasing power?
How do you feel about the liquor division, Mr. Boley?
I'm needing some right now. A couple of big bottles would be all right. Madam Chairman, Chairman Larson, I think we've been having conversations around some of that, and they're looking maybe for an internal solution. But I do think, as we talk about economies of scale and bargaining power, that might be a solution that would work. The biggest problem we have is and it wouldn't apply maybe to all of our hospitals, because some of them have very robust group purchasing organizations they belong to that get those discounts One of the other things that we've considered using rural health transformation funding is creating what we call a high value network, which is pooling together a group of hospitals to create that. And we're seeing more and more of those pop up around the country, but a state solution may be a good option. And I also kind of want to talk about the economies of scale and then I think one of the other things we probably ought to talk about, maybe we'll let Ms. Bush cover it, but we ought to talk about recruitment and retention and shortages. But I think it feeds into this conversation. And honestly, we've offered some solutions, and we could create more economies of scale and have more procedures done in. But it's going to take time to bend that curve. But we see $100 million worth of healthcare go outside our state. We see from the employee health insurance plan itself, I think $45 million goes basically to Colorado. And I think that, and a lot of times it has nothing to do with price. It has to do with referral patterns, or it has to do with perceptions. But if there were some way that we could really work and our hospitals have been trying in certain areas to create centers of excellence in certain areas where we could drive more volume, that's when we start seeing the cost bend, and that's where we start seeing the fixed cost covered. And that's where I think we really can start to see a significant improvement in the cost of healthcare and drive down overall costs. We've also offered solutions. When we talk about solutions, I'll throw a couple out. Bundled payments is one that we've suggested to our local insurer, and we've suggested to the state plan, where it's all encapsulating. If you get a total knee, every part of the expense of that is covered. And bundled payments seem to be working in other areas. Medicare actually has tried to do that. We've talked about direct contracting, where it's where a hospital works with a specific plan and they drive enough volume that they can drive down costs. We're willing to work on those solutions, but I really do think that there is enough business out there that if we could capture more of it inside the state, whether it's through referral patterns or whatever it might be, that we could drive down costs and we could have even better care in our community. So those are just a couple of suggestions that we've actually thrown out over time.
Representative Geringer.
Thank you, Madam Chair. And just kind of leveraging off of what Chairman Larson was talking about, and you mentioned centers for excellence, and I'm not sure if that's if I'm understanding what you're saying correctly, but is there the opportunity to create the cooperative or the group purchasing organization that is statewide, having it more of a privately directed kind of purchasing organization to create those values in the volume? Have you explored that specifically as a possibility? Is there resistance to that kind of thing from the hospitals, maybe from the providers, from the pharmacies? Is there some way to do that collaboratively that way, and is there pushback?
Madam Chairman, Representative Geringer, there's not pushback. And when I talk about centers of excellence, I'm talking about a hospital that does enough procedures of one kind or another that they become very, very proficient in it, drives down costs, quality rises. But back to the GPO or the group purchasing, no, there's not pushback. We'd be happy to find ways to get deeper discounts as we talk about medical inflation and as we talk about the cost of healthcare. And I'm sure this drives the insurers nuts. We have hospitals that do orthopedic procedures. They do total knees, and one doctor wants one brand, Stryker, and the other one wants another brand. They won't use the same knee. And so then you got to have different stock for the different. Could we make that a uniform? And it comes down to, what the doctors feel comfortable with, and some of them cost more and some of them cost less. I don't know if the quality is any better or not. And that's just one example. When you talk about implants and things like that, there's a whole slew of different areas that could be improved if we had everyone that felt the same about certain things. I think another area, as we talk about imaging centers, yeah, their costs are low, right? And all they do is images. But do they have the state of the art equipment, or are we sending them there to get an image? And then when they go to the doctor, we have to do a redundant film, and the insurance company might get charged twice. Or we have electronic health records. We haven't talked about a lot of stuff today that we hoped we'd get to, but we have electronic health records, and we have an original film that's taken at hospital X, and they've got to go to hospital Y to be treated. With electronic health records and with the health information exchange that we have in the state, that image can be sent directly to the other hospital without any problem. But because of fear of lawsuits and with the lack of tort reform, doctor at Y redoes the film that was done at X so that they make sure that they don't miss anything, or that the lawsuit comes and says, well, that was a bad film and you treated them based. So I think tort reform is something tangible that we could potentially do. And when we talk about malpractice insurance in our state, it's through the roof. And our doctors are having a hard time affording to do that. And so what we see is those doctors come under the hospital umbrellas, and then the hospital pays for an umbrella malpractice coverage for all their employees, which drives up cost of healthcare. But we've never addressed the malpractice side. And years ago, we didn't have enough carriers that even wanted to come into Wyoming to provide malpractice insurance to hospitals and to providers. We actually had them leaving the market. And so we came up, the hospital association, we came up with our own solution to help some of our smaller hospitals. And we partnered with Montana and a couple other states and came up with our own malpractice insurance. And it's still very limited how many options are available for our practitioners and for our hospitals to get that insurance. And a lot of it has to do with the fact that we don't have tort reform. And
Mr. Boley, would it surprise you to know that lawyers in the state of Wyoming only have one carrier for malpractice coverage?
that wouldn't surprise me, Madam Chairman.
Do you think that has anything to do with tort reform? Or do you think that has to do with the private marketplace of insurance?
Maybe both, but I do know, Madam Chairman, in our situation, a lot of it has to do with tort reform. We've been told by the insurers that's part of it.
All right, we will take our 10 o'clock break at 10:08, and we'll come back. And Mr. Boley, we'll keep you on the hot seat when you come back, just so you can have an opportunity to have the last word and everybody can think about their questions on the break, because we've got plenty of time here this morning. And then after that, we'll shift to Miss Bush from the Medical Society. Thank you. All right, welcome back from our mid-morning break. Hope everyone is refreshed and ready to go. With that, we will turn the floor back to the Hospital Association, Mr. Bowley. I see there's some pending questions, but would you like to provide any follow-up comments after the break?
Well, Madam Chairman, appreciate that. I actually tried to take a break and I couldn't get out of my seat because I melded into the hot seat here. So I think we've covered a lot of ground. I think just a couple other areas that we haven't talked about, and I know that Ms. Bush is going to cover this too, but when we talk about cost of healthcare in our state, a lot of factors. One that we haven't talked about is workforce and a lot of the challenges that we really face there that also drive up the cost of healthcare. It's a unique state. And when we are recruiting physicians into our state, we're actually recruiting their spouses normally. We find it's very, very difficult in a lot of our rural communities to do that. And so one of the things that we are seeing in certain areas is we're seeing where we're paying sometimes in the 90th percentile for certain positions to recruit and retain those. Again, another big factor, but we're competing against other states that in a lot of ways are more attractive, especially to spouses. And going back to my time as a CEO and recruiting physicians, it was one of the hardest things that we did. With that said, I would really pay tribute to our Wyoming program, our Witchy program, and they're doing a great job. I think one thing that we do see happening, and there are estimates out there, which I think are only going to exacerbate the problem that we're facing. Within the next decade, it's estimated that we'll be short about 250,000 primary care physicians and over 750,000 RNs to fill the gaps and the needs that are already where we're already facing shortages. And because we're facing shortages, a lot of our healthcare facilities are using traveling nurses, which during the pandemic really got out of hand. We went from paying a traveling RN somewhere in the $50 to $55 an hour range to paying $280 for that same RN. And luckily, we had a little bit of an influx of some federal funding to help us offset those expenses. But an example, I know CRMC shared that in a 2-month period, they spent over $12 million on traveling staff during the pandemic. We haven't seen those pay levels get back to normal. They're still inflated, and we're all facing it. It's not unique to healthcare, but it's important to healthcare. We're all facing inflation. We're all facing increased costs in our supplies, which we're seeing whether it's through tariffs or whatever it might be. But we're seeing the need to really increase our wages to even be competitive with the fast food restaurants in our town. And we're also struggling to find people that want to fill those vacancies. And as this silver tsunami continues to roll, we're going to really be faced with some super challenges in keeping adequate staffing. When you take a look at what the federal government tried to do just recently under the Biden administration, they tried to using conditions of participation. This is in long-term care, but they basically came up with staffing levels that they were going to require us that made no sense except to them. And we are concerned. There's continued talk right now about limiting the use of the funds that we receive on a federal level, making sure that 90% of that goes to payroll. When you consider if the federal government's going to continue to impose those types of restrictions on our reimbursement, how are we supposed to reinvest in the plant? How are we supposed to have a profit? And so I think every industry is continuing to face those challenges, but I think it's super important to realize that we're spending a lot of money to recruit and retain providers in our state, and it's from the top to the bottom. We're being creative and working closely with our community colleges, with UW. We're hopeful that maybe some of the rural health transformation funding can help create new spots or the ability to help with not scholarships, but offsetting the expense of education. I think the biggest problem that we're facing though is there just aren't enough butts to fill the seats. And I don't know how we're going to combat that, but if we continue to have to pay for traveling staff, if we continue to have to bring in locum tenens, which is traveling staff in the doctor's arena, it makes it more and more difficult to control costs because those are the necessary services that we need in our communities.
Representative Pendergraft? Did you have a comment? Okay, anyone else? Senator Love?
Madam Chairman, through you. So we talked about the centralization maybe of equipment and things that we can do to increase buying power. Is there any appetite for centralizing care centers? So we make sure that each community has its emergent needs and then it can do the day-to-day operation. But if we're looking at knee surgeries or heart surgery or any of those things, is there a thought process on how we could centralize those in 2 or 3 locations around the state to make it easier to recruit and easier to retain the doctors? And then those doctors could do maybe local visits in those smaller communities and not have to employ one at each hospital.
Madam Chairman, Senator Love, it's a great question. It's a conversation that we have had. I would tell you that recruiting orthopedics is a whole lot easier than recruiting a family practice doc in most areas. But I think there are ways that we can partner and we can collaborate better. I think one of the bigger problems is, and we have a graph in here, but most services, and this is most services we provide in our hospitals, lose money. And so we've got to have a profit center that makes money. And usually it's the elective procedures, which offsets that. Now, if there's ways that they could partner together, and I think we need to get creative, honestly, I do think it's a great question. If there's a way that they could share revenue and things like that, a lot of it comes down, again, to ownership structure. It comes down to taxing authority, things like that. There might be ways we need to massage that and work around it. And that might be a legislative fix that we need to come up with to make sure that they can continue to receive their share of the tax revenue to offset their losses. But I do think there are some ways, and as we've considered the rural health transformation funding that's going out, part of our conversations were about collaboration and partnering. And I think there are certain areas of our state that make perfect sense if they were all under the same umbrella. And that's, I think, one of the biggest challenges is getting them to work together when they're not necessarily competing against each other, but they're not under the same ownership. And most of ours are standalone facilities. So, but I think it's a great idea.
Yep. Madam Chair, thank you. So following up on that, another thought process and conversation I've had with some of our elderly centers in Eastern Laramie County is with the new legislation passed with EMS districts. A lot of other states have taken the opportunity to increase care and in-home care and opportunity by doctors and hospitals working with EMS districts to make home visits in between calls. And so you have a patient that shows up. Socioeconomic situations are a large indicator of whether somebody's going to go buy their medicines, or whether they're going to take them, what their diet looks like with those EMS districts. So what I'm looking for is a broader, larger picture of what it might look like if everybody partners together. If these are all government subsidized programs, we should be able to work collaboratively to ensure better health for our citizens at a lower cost. And so has the Hospital Association looked at much of that?
Madam Chairman, Senator Love, another great question. And it's also a lot of what we've talked about with the rural health transformation funding. There are incentives in place to have hospitals, in particular our critical access hospitals, take over and partner with EMS services. And then we are seeing an increased utilization of EMTs or EMS personnel, other than just going out on runs and doing the transport, but doing work in our ER and I think expanding to the homes. We've had conversations about that. I think and the EMS districts is an interesting one. So we passed legislation 3 or 4 years ago. I don't know. Time flags as we're having.
It was passed in 23, which was an update to previous law. The bill barely passed,
Barely passed. Yeah.
and it came with great political cost.
And it hasn't been utilized to this point. I think there was one attempt, or there's been conversation about creating those EMS districts to help pay for it. And I think that's another interesting conversation that we should have. And as we sat in the gubernatorial debate last week at the health summit that we had, our gubernatorial candidates talked about it, and there's a misunderstanding out there that EMS is an essential service. It is not. It's not funded by county or state. We have a lot of independent services that really need more expertise to help them. And so I think that's where this rural health transformation funding idea came from. And then we also need to look obviously at the education levels that are necessary in EMS. There's a big push to have everyone become paramedic, which is it's a big standard. And when you talk about how much education is needed, especially in a volunteer service, it's not going to happen. And so we think that maybe by some of this investment with rural health transformation and getting hospitals more involved in that, one, we'll see an improvement in the way that it's billed and reimbursed because they'll get cost-based reimbursement under a hospital district. Secondly, you'll have a more cohesive group that could maybe do some planning and utilization of all of the skills of those that work in the EMS services.
Madam Chairman, thank you. So what I believe they've seen in other areas when they work those together, and that the physicians and the hospitals help with the funding on the EMS districts and use them for in-home visits, they're seeing less emergent calls out of our elderly patients because they're ensuring they're getting the healthcare they need. They know what their issues are, and we find ways to solve those things at home. And so it's driving down healthcare costs in a lot of communities. And so it's one avenue I would like for us to look at as we work through this. So,
Madam Chairman, I think it's a great idea, Senator Love. And we have a tremendous amount of calls where it basically is a wellness check. We have our EMTs respond, and they basically transfer mom or dad from the bathroom to a bed or help them. And I think one of the other things that we have talked about and need to decide is there's no reimbursement for those calls. And so we're trying to stabilize the system as a whole, but I do think that in-house care makes a lot of sense.
Representative Pendergraph.
Thank you, Madam Chair. Mr. Bully, you and I were talking on the side yesterday about the drive in medicine towards specialization. Everybody wants to become a specialist and focus on that. And in a rural setting like Wyoming, that runs counter to our needs. We kind of need jacks of all trades. We need general physicians. Hard to do that. You mentioned just a few minutes ago, it's harder to recruit them. How do you try to recruit that type of a general practitioner? We talked about the maybe pressure to change the pay scales. Any ideas on that? I mean, short of forcing somebody to sit down and watch 2 years of Northern exposure, how do you encourage that sort of practice?
Madam Chairman, Representative Pendergraph, yeah, it's an interesting conversation. And honestly, we've had conversations with Blue Cross Blue Shield on potentially looking at the way that we pay our providers. And it hasn't happened, but if we were to pay family practice docs more, if we changed the way that claims are paid, and it might incentivize them to be, as our students go into the WWAMI program and as they decide what their area of specialty could be. It's a thought that we've had and that we've talked about over the years, is how do we kind of created this situation where we have a certain set of providers that are pretty much guaranteed a pretty nice lifestyle and we pay accordingly. Does it make sense for us to maybe change that payment structure in a way that family practice becomes one of those desirable professions? And I remember growing up in a small town where Dr. Richards was my doctor for everything. He delivered my brother and he fixed my broken leg and gave me my physical for high school football and all of that stuff. And so, but we don't have that anymore, really. And so when we recruit, especially family practice, it's hard to find that right fit, and realizing that more than likely in our hospitals, they're going to take call every third day. And in a lot of cases in our small hospitals, family practice docs also deliver. And so they're going to be on call for labor and delivery as well. And some of them really glom onto that and love it. And others, they don't want that because it doesn't give them the quality of life or the lifestyle that they want. And so that's why I think we've seen some shift to subspecialties and things like that. But I do think there might be ways that we could incentivize folks to look at that profession more.
Thank you, Madam Chair. A follow-up. It appears to me that one of the reasons family practitioners have diminished has to do with insurance, malpractice insurance. Do you think that there is anything that could be done with tort reform, which might, if somebody comes out and they go into practice and they look at that hurdle, being able to afford that, and it's easier to go into a clinic or an association or a group and have that umbrella there, is there a way to begin to work on it from that perspective, you think?
I think it, Madam Chairman, Representative Pendergraft, I think it deserves some study and consideration. What we can do to alleviate some of those concerns and fears. And in particular, I've heard in our state, OB is one of the areas that there's a tremendous amount of concern when it comes to the malpractice side of things.
Yeah, we'll go to Mr. Red, and then I'd like to call on Commissioner Rude to follow up with any concerns about malpractice insurance coverage. Mr. Red?
Madam Chairman, thank you for the time. Following up on something that Representative Pendergraft said, and also you, Mr. Boley, we've spoken about investing more in primary care. And I think that is absolutely something that we find to be an important thing. We talk about the rural healthcare transformation dollars that will be coming, and investments into wellness, preventative care, essential care, I think is an important measure for the use of those funds. There are some inefficiencies in the delivery of healthcare. I believe that's obvious. And in the state of Wyoming, I think that we see some of that bubbling up as well. And some of the data that you shared here on Wyoming healthcare capacity workforce metrics, you indicated some data from 2017 that Wyoming and the surrounding states found that Wyoming had the lowest physician ratios of all surrounding states for 11 of the 26 specialty types analyzed. For 22 of the 26 specialties, both Wyoming and its surrounding states fell below national averages. So when we talk about specialty types, we have 30 plus hospitals in the state of Wyoming. I think while not a one-to-one comparison by any means, the Front Range has about the same population as the state of Wyoming. They have about 5 hospitals. In Wyoming, we have over 30. So I guess the question I would have is that if we're going to invest more in primary care, are we thinking about continuing to invest in these specialties, or is that what we're suggesting here? I don't know if it is, if this is just a statement in the materials that were provided. And will that lead to a lower overall cost of the care that's delivered in Wyoming, or would it potentially lead to a greater amount of cost in the state of Wyoming because we're investing in primary care, paying our primary care doctors more, but then does that lead to figuring out how to deal with the other end on the specialty side and the great cost that we see on that side?
Madam Chairman, Mr. Red, I think that's a good conversation. I think we need to have that whole conversation. I don't think in any way we're suggesting that we need to recruit more specialty. We're just providing the statistics. I think the Front Range analogy, yeah, they've got the same number of hospitals in the Front Range that we have, but they're also much closer when you look at the geographical distances. And I think that needs to be a huge consideration. And I don't know who's going to decide if we decide we have too many hospitals, who decides to tell which one they need to close their doors.
Mr. Bowley, thank you for your time this morning.
Thank you.
Madam Chair, thank you. Just for some history, some context. Back in the 80s, there was a very bad malpractice insurance carrier crisis in the state. And the state did a couple of things. And one of the things they did in statute, they required my department to look to see with medical malpractice, is a market competitive? And we included it for years in our departmental report that went to the governor. And so we've done that. And since I've been with the department, the market's considered competitive by definition. We have enough carriers writing. That doesn't mean it's affordable, doesn't mean it's cheap or enjoyable to pay for, but there are carriers there. We can certainly look at tort reform. We can look at whatever we want. We have such a small, going back to the demographics of Wyoming, we're such a small state with such a low population. I don't suspect we will move the needle. Most of these carriers write malpractice insurance in more than one state. And so our low population may not really get the impact that you want. If you still want to go down that road, that's fine. But I just want to have reasonable expectations on the possible outcome of that.
Thank you, Commissioner. All right, thank you. With that, we will turn it over to the Wyoming Medical Society. And we have Sheila Bush with us here this morning. Welcome, Ms. Bush.
Good morning, Madam Chairman, members of the task force. Sheila Bush with the Wyoming Medical Society. A couple of disclaimers before I get started. When I was asked to present, I wasn't really sure what lane the committee would want physicians to play in this conversation. And so after listening to yesterday, I feel like I have put together some comments, some of them piggybacking on things that have been said, some of them adding a little bit of context or potentially a different perspective to what has been said. I do apologize, I don't have handouts. I don't have a slide deck for you to have to follow either. I will say that everything that I'm going to talk about, including any statistics, I do have written down and I'm happy to share that. So I'll make sure that anybody who wants that has that so you don't feel like you have to scramble or follow.
And Ms. Bush, just for those that are watching, if you want to just provide a brief 30,000-foot explanation of the Wyoming Medical Society, its origin, what it is, what its purpose is, that'd be helpful.
Yeah, I'd be happy to. The Medical Society was formed in the early 1900s. We represent the physician voice as well as the physician assistant voice. It's really our primary duty to ensure that that provider specific to physicians and PA's perspective is included in important conversations like this one. And so we have about 50% of the state's physicians who are current members. They make a decision every year whether or not to be a part of our organization. In loose terms, we can sometimes be seen as the counterpart or the younger sister to the American Medical Association, which can be good or bad, depending on the conversation and the day. But that is, there are 50 of us in every single, there's one of us in every single state making the 50 or the 51, however you count Puerto Rico. And that's kind of who we are.
And Ms. Bush, not to throw you off with what your prepared remarks are, but I took note from, I think, the Department of Health's presentation from Mr. Fuchs that the Wyoming Medical Society helped work with its state partners, I think, to create what is now today Blue Cross Blue Shield, recognizing that it's the medical providers in Wyoming at that time in the 40s, I think 20s or 40s, had decided that Wyoming citizens needed access to health insurance. And so they were part of creating that.
Yes.
Fun fact.
Yeah, it is a fun fact. The Medical Society also proudly was the original partner that held the MOU with the University of Washington to form WWAMI. So yeah, I think what we pride ourselves on as an organization is being partners in conversations like this, sometimes being able to bring a different perspective or a sense of calm to what can otherwise sometimes be tense conversations, because often, and thankfully, physicians aren't the subject of as much scrutiny or arrows, and they can bring that perspective that just sort of bridges all of the conversations and all of the players that are part of these really complex and nuanced policy areas. So I would start those comments by just saying, I think when I heard about this task force and really studying the affordability of health insurance, and in conversations with Representative or Chairman Larson, it to me seems really clear that it's always going to end up backing up to the cost of healthcare. I think the cost of insurance is just a byproduct and a symptom of a system that is deeply fractured and broken in many ways and doesn't function all that well all the time, with really isolated parts that don't always work in complement to each other. And so what we see in insurance premiums is often the catch-up of trying to make whole what all of these systems are trying to do. And so any of the comments that I make today are in no way intended to cast blame or shade to any of the players in that. I think, the big takeaway is everyone is doing their level best to survive. And anything that you see nationally, statistics or otherwise, more often than not are deeply exacerbated in a state like ours because of our rural and frontier nature. You have a huge land mass and not very many people. And so, the simplest way to talk about this conversation is just simple math. And it's been said a couple of times, but we do have really low volume. And there is a fixed cost to what I would term as readiness. And so there is an expectation in this contract that society has with healthcare for a certain level of services to be available. And that might differ depending on the conversation you have with different people. But that readiness at the base level has a certain fixed cost to it. And so if you take an emergency department in a rural community in Wyoming, if 3 people visit that emergency department overnight, whatever that fixed cost for that infrastructure to be present is spread across those 3 people. And that exact same emergency department and the same components required for the readiness in a more rural area might be divided over 50 people or even 100 who visit that evening. And I think that simple math equation is the reality of some of everything and grounds so much of what this conversation is going to include. So with that, I was going to offer a couple of statistics, mostly because I found them really compelling. So the Gallup Center on the Healthcare Report ranked Wyoming 39th overall nationally for healthcare experience. 36% of Wyoming residents claimed to avoid a doctor-recommended procedure because they could not afford it. 34% reported that the distance to a medical professional in our state prevented or delayed care. A 2023 Better Wyoming study concluded that Wyoming ranks nearly dead last among the Rocky Mountain states for affordability and accessibility. We have the 6th highest rate of uninsured adults nationally. It's approximately 16%. And 1 in 10 of our children in Wyoming don't have any insurance, ranking us the 2nd worst in the country. So that's all really fun. Yesterday there was a conversation about the evolution of insurance. And so I wanted to bring a little bit of, as the conversation was unfolding, I had several thoughts that I thought would be important to maybe add. I think everything that said was true. I would also say that in addition to the employer sponsor coverage being a contributor to the evolution of insurance, tax policy, federal regulation, it's also the growth and the development of chronic disease management, and a recognition both by government players and policymakers recognizing that care delivered early and preventive care is a far more affordable way to address health concerns. And so much of what I'm going to talk about today, both in the history of EMTALA, but also the role of primary care, can be rooted in that notion that care delivered early, diagnoses that happens early, will always be a cost saver. But more importantly than that, It's going to keep people healthier and happier and at work longer, which I think, even though we haven't talked about it as much, is the ultimate goal of all of these conversations, is to make that ultimate consumer and the patient live a happier, healthier, better life here in the state. So I wanted to talk a little bit about EMTALA. It was mentioned, so I won't belabor all of it. It is the Emergency Medical Treatment and Labor Act. It requires a few things of hospitals. It creates mandatory obligations that hospitals must provide an appropriate medical screening exam for anyone who comes in. They are forced to maintain a list of specialists who are on call in the event that that emergency department team decides that a surgical specialty or a surgical procedure is necessary, anesthesia, et cetera. They have to provide all necessary treatments, including hospitalizations, if it is deemed medically necessary and it is categorized as an emergency. And finally, if that hospital is not equipped to take care and stabilize that individual, the law requires that they facilitate the required transfer. Some context around EMTALA is that prior to EMTALA, in 1946, U.S. Congress passed the Hospital Survey and Construction Act of 1946. And this was an agreement between the federal government and the states that they would pay through grants and loans for hospitals to modernize and develop their facilities in exchange for those hospitals delivering a certain amount of charity care or care for the poor. So fast forward from 1946 to the early 1980s, and it was found that hospitals were not always complying with their end of that deal. They had taken the loans and the grants, but weren't necessarily taking care of the patients in the way that the federal government at the time had envisioned that they meet that obligation. And so I think I have a stat in here that 86% in the early 1980s, 86% of patients were being what's called patient dumped. So facilities were transferring them somewhere else. As soon as they found out that they didn't have a means to pay, those hospitals would take them somewhere else so that the burden wasn't theirs. And so a lot of that pressure at the time is what led to the development and ultimate passage of EMTALA. And I think EMTALA now can simply be stated as the moment when the US government told the American people that there was a level of a right to care, and it's a right to emergency care, but there is a floor under which this country decided people shouldn't be able to fall under. And that is what EMTALA did. So many in a negative context would refer to it as an unfunded mandate, because while there's the obligation that is set out for hospitals, a payment mechanism for that never was. And I think that that can be explained when you look at it within the context of what that law was before, right? So if you look at EMTALA next to and jointly with that 1946 Act, it makes more sense. It didn't come out of nowhere. And the federal government felt like earlier they had made that payment. They had funded the development, building, modernization, whatever that looks like or looked like to them. And so when EMTALA came in, yes, unfunded mandate, 100%, and it has this history that matters, and I think feeds into the whole conversation. But it is today, in 2026, this big component of all healthcare cost. It's a driver of uncompensated care, which Mr. Boley spoke about. It also, I think, is, whether consciously or not, a major shaping tool in patient behavior. And so, again, I'll get into more detail quickly, hopefully, about primary care and about delayed care and the cost of that. But when we talk about responsibility and patient management of their own health, we have entered into this agreement that says if you can't afford it, or you don't go get insurance, or you don't do preventive healthcare things, when you get sick enough, we have a contract that says we will always keep one of these doors open to you. We'll never let you fall completely underneath all of it. And so I think that, not to say that that's ever abused intentionally, but it can feel or be interpreted that way. Yesterday, we talked a little bit about, and we hear it often, that health insurance, we like to compare it to automobile insurance. And I guess every time I hear it, I get a little twisty because they're very, very different things. And I guess most simply, and you'll have to forgive me because I'm not a physician nor an auto mechanic, so all of this is bound to get a little off probably. But I think when you think about it, if I fail to do any of my preventive care, I don't go to regular well visits, I don't pay attention to symptoms that are kind of nagging but don't feel like a problem. If I do get to that point where I'm sick enough that a hospital would deem it an emergency, a medical emergency, I will get seen. It might not be the comprehensive everything, but I'll get stabilized. I will have a door into medicine. It will be the very most expensive door that we can make available to patients. Conversely, I make a choice to buy a car. That's in many ways, that's a luxury. And then I'm legally obligated to have that insurance, not in a way where there's a penalty, but it's actually $0, but in like a real, I've broken the law. If I get pulled over and can't provide proof of insurance, we're all familiar with that piece. And further, if I don't pay the maintenance, which yes, arguably is all out of pocket for me, it's my fault if I don't change the oil. If that engine seizes up, which I think is what happens when you don't change the oil, but I don't know. Representative Geringer's face would say that's not what would happen, but I don't really know. If I don't do any of the things that I'm supposed to do to take care of my car and it fails to start one morning, it's just a dead car in the driveway. Nobody is coming to help me get a new car or fix that one. And so I think we have to be really careful as this conversation continues to create analogies that take two wildly different things. Especially with one of them having this component of EMTALA attached to it that completely shifts the social contract that exists between the American people and our healthcare system.
If you'd help me just clarify in my mind EMTALA and who it applies to, because I thought I have it in my head that EMTALA applies to any hospital who receives federal funds. And if they didn't receive federal funds, which I'm not aware of any, but if they didn't, it didn't apply. Would you correct that for me?
Mr. Chairman, I would let Mr. Boley, but yes, you are correct. It is a condition of participation from
So
Medicare.
I think in your presentations, I would have gathered that you imply it applies across the board. Is this universal standard that all hospitals have to comply with? But if they're not taking federal funds, they would not.
Mr. Chairman, Madam Chairman, Co-Chairman.
No?
I think both can be true. I did mean it, and I would stand behind the fact that we do have this overarching umbrella that creates a contract between the American people that if they get sick enough, there will be a door open. They will be able to find a hospital who is obligated to provide them care. So could they find a hospital that doesn't have a contract with Medicare where they wouldn't be given that care? Sure, but they could go to the next one and still receive the care.
Madam Chairman, and I agree with that. I'm just, I mean, I'm dotting I's and crossing T's on this, and I don't disagree that that's the intent of EMTALA, but the requirements of the hospital and the impacts of the hospital really revolve around those federal dollars that they accept or that they get. But I question myself because I may not be right. So,
According to the Oracle, which is what I called
the
it.
Great Oracle.
Great Oracle, which is the internet, now commonly referred to as AI. So use cautiously. It covers EMTALA covers almost all US hospitals, but it only applies to hospitals that participate in the Medicare program, as Ms. Bush identified, and offer emergency services. Yeah. So it's those two pieces. But the Oracle further explains that there's virtually no US hospital that exists that does not receive Medicare funds. So recognizing that the population over 65 probably uses hospital services more than anyone else, and it's not a sustainable model to not care for that population. So it's Maybe the state of Wyoming could cover those costs.
No, that's good. I just wanted to clarify it. It really doesn't apply to Wyoming. It's just one of Larson's goofy.
Madam Chairman, Representative Larson, I would say that you're absolutely correct, and I maybe misspoke or too broadly characterized its role. I think what I intended to do is to educate on its role and how it functions as a driver of so much of this conversation and impacts or pushes dominoes that have meaningful impact in everything that we're going to talk about in this meeting and subsequent ones. I think you're right in terms of the very detailed nuance of it, but I think the overarching concept remains the same. So I think it's important too, because, and I will, like I said, I will share this with you. But if we take just one condition, so maybe diabetes, and I asked the great oracle to give me this example, and it is in the document that I will share with you. I was given some really interesting information, both from the CDC and some other sources, that said that if an individual with some pretty early symptoms of, let me stop and back up. This feeds into a conversation around access to primary care, the role of preventive medicine. I also think it's important right now to have like a little bit of an asterisk and go back to yesterday, because there was a presentation made where I took from it maybe that there was less of a value being placed on preventive medicine. I was later educated and told that I had misinterpreted that. But I do think that the terminology and the vocabulary matters. When I talk about preventive medicine, I mean opening up that earlier door to healthcare. So I had talked about EMTALA sort of keeping this emergency medicine door open, which has dollar signs all around it. And when I talk about preventive medicine, what I'm thinking of is the ability for a patient to have a relationship with a primary care provider, for me, in a perfect world, a family medicine specialist, where they have a relationship, they have an ongoing space in which they can make appointments and get seen, and my utopia, if you will. And so any of this conversation, when I talk about preventive medicine, I am talking about that. I think yesterday's conversation was maybe looping in that and other things, or maybe something entirely different. And so at some point, it's probably helpful for me, again, to be educated on what that was intending to define and what I mean by preventive medicine. But for this purpose, I do mean that access to primary care. So this example is diabetes. I looked up what the early signs of type 2 or prediabetes were, and they're not things that would necessarily be a flag. If you were in a socioeconomic situation where you had to choose between buying groceries or seeing a physician, being overly thirsty would not be something that would probably get you to spend that money in that space. The list of symptoms, there's 8 or 9 that Google provided. None of them really broke as wild flags for me. Yet, if you look at some of this data, so any of those symptoms, if they went to a family physician and said, hey, I've had this, I'm a little concerned about, if it was type 2 diabetes, the cost would run $4,500 to $5,000 per year for a person with insurance who was diagnosed early and treated with insulin and then had regular appointments with their doctor to monitor their glucose. The lifetime direct medical cost for someone diagnosed runs about $106,000 spread over decades. The CDC added that regular foot exams and patient education alone could prevent up to 85% of diabetes-related amputations. So you get into amputations, which is, again, in my scenario of I don't have an access point into healthcare until I'm so sick that it's undeniable and I've now landed myself in emergency department. At that point, that delayed care leading to amputation, the numbers change dramatically. So the cost spirals out of control. A foot or a leg amputation costs $30,000 to $60,000 in just the initial hospital cost, plus another $40,000 to $60,000 in follow-up care. Major amputations average $73,222 for the hospitalization event just by itself. And that's just the beginning. For a person with a unilateral lower extremity amputation, the 2-year healthcare cost, including the initial hospitalization, inpatient rehabilitation, outpatient physical therapy, and prosthetic device will cost over $500,000. I think that that paints a really interesting picture about the value of preventive care and probably explains a lot of back to why I don't think health insurance can be compared to car insurance. When you have this contract that when you're sick enough, we're going to pay the $500,000, the US government through time, and then particularly at the passage of the ACA, said, what can we do in a policy sphere to pull levers to incentivize patient behavior? Recognizing that at the end of this stream, we're going to be holding the bag or we're going to be shouldering the cost. We as a community, we as taxpayers, we as premium payers, because that uncompensated care for the individual who comes in that sick and can't pay goes into that uncompensated care number, and through time ends up, someone has to fill the gap. And we have cost shifted enough through time that we have an expectation that private insurance will bear at least some of the burden to fill that gap. And private insurance can only do it so long without increasing the premiums to all of us. And so I think that those are the things that all back up to push the dominoes to say, this is why we have all of those things baked in as essential health benefits, because it was an attempt to look at numbers like that I just provided you and say, okay, if we know that we can save that amount of money, again, not to mention the health of the patient themselves, which really is the most important thing. But if we can do both by putting these incentives in or saying, hey, we'll pay 100% of that visit if you'll just go once a year and talk to a physician about how you're thirsty all the time, then we're going to save not only the system, we're going to save maybe you from an amputation or something really dramatic down the line. And overall, as a community, this country will spend less money. And so I think that that's really important to understand as we continue the conversation.
I agree with the theory of that, Mrs. Bush, but I think what I heard yesterday, that in practice, evidence hasn't shown that has generated the outcomes that you suggest. Now, I think every one of us would agree that if I do that, it will save money. But humans being humans, even though the insurance pays for it, may elect not to. And I think that's kind of the take home I got yesterday. And so then if people are electing not to do that at a higher percentage than those covered who do it, should it be required to be covered, right? Because it's a cost. And so I that was my take home from what I heard yesterday. And I don't argue with how you present it. I just think people are people, and oftentimes they don't take advantage of those opportunities. And so we don't realize the overall impact of what those could do. Am I seeing that wrong?
Madam Chairman, no, I would never tell you that you're wrong, ever, period. So a few things come to mind. First, back to, I think we might have a vocabulary. When I heard all of that data yesterday, I had the same sort of like, oh no, does the data actually reflect that preventive care doesn't matter? What I was told later is that some of what was being talked about was employer provided incentive programs that get put into insurance programs like gym memberships or incentives to improve your diet. So that may be kind of what I was thinking about, like maybe we should really be clear about what aspect of preventive care we're talking about. Secondly, I think you are 100% right. I think it's really hard to change human behavior. We know that. You know it better than anyone sitting on the legislative side of this conversation. Also, those two things can be true, and we can look at the data from other developed nations who put a disproportionate level of their healthcare investment in primary care and how much less they spend, and their health outcomes are better. And so is Sheila Bush pulling out what she wants from the data? Probably. I'm human also. But when you look at the investment of the United States in primary care, which ranges from, I think, 3 to 5%, versus other developed nations, which are more than double that, and then you put that inside of how much the United States spends as a total on healthcare in comparison to those other nations, it's a really impressive image that you get. This document that I will share with you has a graph, but it has the United States all the way at the end with this bar graph that's really high on our total healthcare spend. And then it has 8 or 10 countries across the bottom that span, that decrease as they go. And then there's a green line that places those countries' investment in primary care on top of our total spend. And that green line in the same picture over on this left end under the United States is as low as it goes, and then takes a real significant sweep up to the very end where I think it's Australia spends the least on healthcare and the most on primary care. And so that would tell me we're doing something wrong. And I don't know how to fix it, but I do know that the data around primary care and giving people access to that preventive space where they can talk to someone and get things answered and get screens done and get vaccinations and do procedures that will indicate other problems down the line. Not only does it make them healthier, but we know that the data is pretty clear that it does save money. Okay. So to that, I wanted to give just a couple of statistics on family medicine and primary care. And some of them I've touched on, but I wanted to sort of just to put a finer point on them. So this is according to the American Academy of Family Physicians. They produced an importance of primary care document that's linked in this document I will share with you. In the US, an increase of 1 primary care provider per 10,000 people found a decrease in both infant and adult mortality and a 3.2% reduction in low birth weight. Patients with long-term relationships with a PCP, primary care provider, are less likely to visit the ED. U.S. adults with a PCP had a 33% lower health care cost. This is, again, where despite the significant role that primary care plays in our healthcare system, in the United States, it accounts for a mere 4.7% of our total health spend, compared with all of the OECD average, which is 14%. Interestingly, all of those countries included in the OECD average also have longer life expectancy. We spend half of what other industrialized nations do on primary care as a percentage of our total healthcare spend. What else is interesting is in those developed nations, sometimes some of them are reporting that 85% of their entire physician workforce categorizes or characterizes themselves as primary care. For me, when I think about primary care, I think of internal medicine, family medicine. Often OB/GYN gets captured in primary care because of the way females use their obstetric provider up until a certain age, and pediatrics often gets looped in also as primary care. So again, a place where the definitions matter. For purposes today, when I think about primary care, those are the specialists I'm thinking of. Also, just as a note, family physicians are a specialty. We don't really have general practitioners in the sense of that using that word anymore. Family medicine is considered a specialty, but it does sort of, for your conversation, Representative Pendergraph, does sort of check that box of the general practitioner. But for us in medicine, when we talk about it, we think about family medicine as a specialty. There was a study in Rhode Island done that from the years 2008 to 2012, they did kind of a concentrated study, and they increased spending on primary care by 37%. And in those 4 years saw a 14% decline in the total healthcare expenditure. So even in really short-term studies, the rate of return is also pretty quick in that investment. Before I move on, are there questions about primary care or how much I love it? Okay. So the next thing I'd like to talk about a little, and I offer this with a really bolded asterisk, is the role of physician employment and healthcare consolidation, and whether or not it warrants a conversation. But I would offer all of it with the disclaimer that without our hospitals employing our physicians, in many of our communities, we just wouldn't have physicians. So despite some of the data that I'm going to provide, none of it is intended to villainize or demonize this practice. Physicians desperately needed that lifeline, especially at the time when this trend really kicked up. And it's with great appreciation that we have that partnership between physicians and hospitals. So that all being true, I think it also is important in a policy conversation to look at what that did to cost in the system. So consolidation, the Physicians Advocacy Institute in 2000, well, I don't know when this study is, it found that between 2019 and 2024, rural areas nationally lost nearly 2,500 physicians. They saw nearly 3,300 rural medical practices close and had a 43% decline in independent physicians. It also reported that by January of 2024, 76% of rural physicians were employed by hospitals, health systems, or corporate entities, and 61% of rural medical practices were owned by non-physicians. Consolidation in rural areas, again, it's necessary. I think that it's something that a lot of different pressures in medicine led to, EMRs being at the very top of that. I also don't mention that to demonize EMRs. I think that in concept, they were really smart and we shouldn't abandon the utility of them. I think the way they were implemented, the rules around them, the multiple vendors, and the cost associated with EMRs has been devastating to healthcare. But none of that is to imply that I don't think that in concept, the ability for you to have, the equivalent of a debit card that has your health information that you can share with anyone isn't really smart. I think that that's good. The way we've done it in the United States maybe is the worst that we could have. I don't know that we could have done it worse than we've done it here. And so the cost associated with that, I think even just anecdotally in my time with the Medical Society, I was pretty early in my career at WMS when I started getting phone call after phone call saying, I'm either leaving medicine, I'm going to retire early. I cannot afford to meet the requirements of these EMR obligations. I can't do it. And so I think that alone sort of led to this big transition for physicians to be employed. Physician employment trends do, the data shows, contribute to the cost of care. The ownership, I think different things can be attributed. It's ownership, it's the billing structure. Sometimes it's the referral patterns that are included with that employment agreement with a certain system or hospital facility. And the negotiating leverage changes when you have consolidation and you have one larger entity negotiating with an insurance payer as a whole versus individuals. It also changed the dynamic between physicians and hospitals as community partners, where both held cards in an equal footing way. When physicians had people that would visit their clinic and then if those patients needed hospitalization, they rounded on those patients. They followed their care through the hospital and back out. It really was a different time. There were problems with that time, so it's not to be overly nostalgic or romantic about it. But some of the data does indicate that the Government Accountability Office reports and estimates that the consolidation of physicians led to an 11 to 17% increase in cost of care. Sometimes that means that the exact same service being delivered in a clinic is exponentially higher when it's billed as part of a hospital. Again, now I feel scared. I don't want to make anyone upset. I just think that the numbers are the numbers. And so some of that is, and Mr. Boley can speak better to this, and I think that the conversation should happen in partnership, but it certainly lives as a cost driver and one that needs discussed.
Can you restate that statistic?
Yes. Let's see. The Government Accountability office reported in 2025. Oh wait, that's the wrong one. Sorry. So yes, okay. Shifting office visits from physician offices to hospital outpatient departments increased traditional Medicare spending by $615 million and beneficiary cost sharing by $150 million from 2015 to 2019. The percentage that I gave you came from a different report. I think that's the Physician Advocacy Institute, and it estimated that physician consolidation was attributed for 11 to 17% increase in the cost of care.
Thank you, Madam Chair. Thanks for being here this morning. I'm curious, do you see any state policies that are unintentionally accelerating that consolidation?
Madam Chairman, Representative Garrett, no, in fact, there's some that might be helping to remedy it. A bill that passed this past session that was Senator Nethercott's around non-compete could potentially play a role in helping the situation. I think what we saw is physicians were carrying really heavy things, and the regulations and the requirements were building up on them to the sense that they couldn't remain independent any longer. And so they entered into employment agreements. And sometimes those relationships are wonderful and work really well. Sometimes maybe not as much. But if they ever wanted to leave that employment, those non-compete contracts would have prevented them from doing that. Because there's radius miles or requirements that they can't practice or hang, I mean, there's a million reasons that non-compete, you can argue both sides of all of them, and I'm not here to have that debate. But I think that laws like that can actually help. It's not going to apply to any existing contracts. It's only new ones, I think, after July 1st that it would apply to, if I'm not mistaken. But that could help. I don't know that there's anything in the policy sphere other than the expense of what it was costing to be independent. And I think that you get into some of what Mr. Boley touched on with recruitment. So here in Cheyenne, we have a couple of primary care clinics that are independent of the hospital. As those physicians reach ages of retirement, they're faced with not really are they going to find a graduate to come in and buy their, the equity that they have in their clinic is a really hard proposal. And we're not necessarily training physicians in a way that sets them up for success in independent practice like that anymore. The trend toward employment is pervasive. And so I don't know.
Thank you, Madam Chair. Yeah, and actually a follow up on what you just said, at the risk of opening up a whole other can of worms, the Business Council did have a program to provide the means by which to provide succession funding for existing businesses. Not saying whether or not that's the right thing to do or not, but is there something available like that, or should we be looking at something available like that where there's a vehicle by which to help in that sort of succession from an existing practice with an established doc to a new doctor?
Madam Chairman, possibly. Yeah, I think that there's all kinds of options. I think there are other part of the cost when you unpack this increase in cost where a physician visit in a clinic is reimbursed at a different rate than that exact same visit happening in a hospital. Maybe rather than incentivizing physicians to go back into independent practice, which maybe the horse is out of the barn, maybe it's unpacking what is being charged so much more in that hospital setting than in the clinic. And I would imagine, a guess would say, the hospital is having to absorb a higher cost by having an ER that has the uncompensated care right? So like this whole puzzle that we talked about earlier is contributing to how much the hospital needs to make on that physician visit in the clinic, because that amount of money is covering a much different set of aspects of health than it was covering in a physician clinic in a small brick and mortar building where their overhead was much less. They had less obligation to the community. That's just a clinic that gets to close their doors at 5. They don't have to have a team of specialists on call because the federal government requires it as a condition of participating in Medicare. That anesthesia services, surgical services, all of those things that we have required of hospitals drive that cost up, and they have to recoup it somewhere. And so they stepped in, they saved physicians in many aspects from what they were carrying. They said, here, give it to us, we'll hold it. Come take care of patients and heal people, which is what you wanted to do, right? So many aspects of this are positive and not at all meant to be overly negative. But when that hospital has all of those obligations and they're recouping those kinds of costs, that same physician visit is going to cost more because it's paying for more things than it paid for when it was a brick and mortar building that closed at 5.
Senator Crum?
Thank you, Madam Chair. 2 questions. First one being, I asked this question yesterday, and I'd like to get your opinion on it. If there was a way to attract more physicians to the state and get more physicians to come here through incentives or, expanding, we heard earlier today about Wyoming and Witchy, expanding those programs, would that be a benefit that would possibly drive down healthcare costs?
Madam Chairman, Senator Crum, I don't have a great answer for you. I don't know that I can answer that in a yes, no, or in a binary sense, because I think there's so much more to it. Simply adding human professionals, I don't think by itself fixes everything. And I think everybody has, again, given really frustrating answers to those questions, which is it's going to be a bunch of kind of 1% baby steps that together collectively create something. Do we have an access problem? Yes. Do more people address the access problem? Yes. Do we have other things that also need fixed in concert with adding more people? I think also yes.
Thank you. And then the second question would be, you mentioned non-compete agreements are holding people back. Is there something in the Wyoming laws that need to be changed? Because I know things on non-compete were changed a couple of years ago where non-competes are almost not relevant in the state. Is there something that needs to be changed there?
Yes, there does. So Senator Crum, yes, in 2025, I sponsored the bill banning non-competes in Wyoming. But one failure that I intentionally included in the bill, because it was pretty significant policy that was being passed with no stakeholder involvement, but nonetheless, it went into effect July 1st of 2025. And I believe we have seen significant results from that. And I've received a lot of positive feedback, particularly in the healthcare industry. But one thing I did out of caution was I put a grandfather provision in there. So anybody that was under a non-compete prior to July 1st of 2025 remains under a non-compete. That, in my opinion, has resulted in an absurd result of having these physicians trapped if they were employed prior to July 1st, 2025. And almost all of our physicians in Wyoming have been under a non-compete at some time, which is, I think, an unknown secret, which will go away hopefully shortly. So I do believe that we have these 2 classes of workers in Wyoming, and physicians is related to this conversation, and nurses too. So you should know that it's very common for CNAs, home health care aides, RNs to be subject to non-competes. So these are $15 an hour employees, sometimes less, sometimes more, who can't get another job. And really harming access to healthcare in our communities and harming their ability to make a living in the professions that they've had their skills developed in. So I would propose, as part of this, looking for feedback, that one thing that this committee could do, and we can't sponsor legislation, we have to give it to another committee, but is to recommend the repeal of that grandfather provision, kind of now eliminating those 2 classes of workers in Wyoming, and healthcare workers notably, as it relates to this committee. So I'll put that out there for consideration. But it's something that I think is critically important and will help this conversation.
Can I follow up? You mentioned just briefly that increasing manpower was maybe part of the solution, and there were other things that need to be done without taking a long time here, but maybe name the top 2 or 3 without, we don't need to get in a big discussion, but name maybe the top 2 or 3 that would be part of that solution also.
Madam Chairman, Senator Crum, I don't know that I have that list of recommendations for you today. I did intentionally approach this space with a really open mind and wanting to be a partner where I offer sort of our perspective of what we see happening currently and an openness to be part of the conversation to develop the recommendations together. I think I would easily tell you that a recalibration toward valuing primary care would be a little bit of a no-brainer for me in concept. Now, the execution of it and the individual steps required to implement that, I'm not positive I know. I think that there's a myriad of ideas that could get there in different ways. Similar to this consolidation conversation, I would want to have the conversation, make sure the data is accurate, make sure it's Wyoming specific. So much of what's available to us is national and doesn't always translate here the same as we would like it to. And so I think that, you know, as these conversations continue, we make sure that we have Wyoming specific data that we can trust objectively. And then once we know that, making sure that whatever recommendations we come up with don't disproportionately hurt any player in this conversation, which is why I've said now too many times how grateful we are to hospitals that they have taken on that role. And so I think if we're too quick to rush into any list of recommendations, we risk prematurely doing harm, and I just didn't want to do that. And so I don't have that list of recommendations for you, and I'm sorry.
Senator Crum, I guess Ms. Bush, and to others in the room, one area that I think as it relates to this concept of consolidation is maybe further discussion around antitrust provisions for healthcare practices. So that's something I intend to look at and have previously enhanced our antitrust statutes to protect primarily ag producers, but I am concerned about the lack of attention to the healthcare field as it relates to antitrust, anti-competitive nature. So something for you to ask your doctors to ask their attorneys about and to hear some feedback on.
Madam Chairman, Ms. Bush, a couple quick comments and maybe a question. I appreciate the information that you gave on preventative service, wellness services. Like you yesterday, of course, I was a little bit saddened, no offense to Mr. Fuchs, by some of the comments that were made because as Mr. Boley mentioned earlier, we have been committed to finding solutions to lower the overall impact that sick care, as we call it, finds its way into the state of Wyoming and increases the overall cost. And so for us, again, reiterating again, what our purpose for this meeting is to lower the overall cost of healthcare in Wyoming. And we want to be here through thick and thin in finding ways to do that. So talking about that sort of opposite curve data that you had mentioned, I think that makes us actually more interested in continuing to study how preventative care could help the state of Wyoming and reduce the overall cost of care, even if other studies have suggested otherwise in lower data fields or the way that they're studied. So we would certainly, as the Hospital Association mentioned, like to get together and have this discussion and work together as we have in the past. And I completely agree that we have worked together on several bills, had lots of conversations with the Hospital Association, with the Medical Society, and work together. And I think that's very important that we open and keep open the lines of communication that we have between each other. The other thing that I wanted to mention is that when we're talking about this concept of consolidation, I mean, I think basic economics would indicate that the more competition that you have, the more likely you are to make it better for the consumer. So you can see that competition would increase the ability for the consumer to find a cheaper option or a better option because there's competition. They're seeking for that. And with consolidation, I think the data that we have seen is very similar to what you have seen, which suggests that outpatient hospital services are where that cost is being moved over to. So when you have physician offices that charge, physician rates, and those have been consolidated and moved over to outpatient services, what you're doing is you're paying for hospital outpatient services. But the same exact service that you're paying hospital outpatient services for, if you were to pay at a clinic, would be significantly less. And so the question is, should we be paying for the same exact service that's being provided in a hospital at a much greater amount, or should we just pay for the service that's being provided? And that service that's being provided at a clinic would be significantly lower. And if we did that, would that actually increase competition in the state of Wyoming and maybe be more likely to welcome in other physicians who want to provide that service in their own clinic and not have to work for a hospital? And I think that's a good question to ask. And would it also result in an overall lowering of the healthcare costs in the state of Wyoming? And I think that is something that we should get together and have a discussion on. And I would be willing to come to that discussion, as I've been willing to come to prior authorization discussions and credentialing discussions and other discussions that affect health insurance companies. And while I understand that that discussion may affect others in this room, I think that it would be important for us to probably meet together and have that discussion.
Madam Chairman, so much discussing. I'm excited. Yes, I would also urge caution around the notion of competition working the same in healthcare economics as it works in, let's say, retail economics. There are so many components in healthcare that make competition not the same component of the equation that it is when you go to the grocery store and pick your cereal, right? There are a lot of other pieces all contributing. And so I don't know that the data is all that clear that competition actually drives down price. I think it depends on if you're talking about an elective surgery or if you're talking about something that's an emergency. Someone at our healthcare summit last week, as part of their, I think it was in the gubernatorial forum, the preface to one of the questions was, someone having a heart attack 80 miles away from a hospital is not making a market choice when they dial 911. And that all gets absorbed into the same ecosphere and the same economic picture. And so is competition a really important component of someone making a very calm decision to do a wellness visit and they can call around and see which one is in network? And yeah, maybe that has a place there, but then it doesn't have a place over in like an emergency situation. And all of these pieces have to work together and complement each other and not work in opposition to each other. And so I don't know. I guess I'm way out at the very tip of my skis on what I do know, but I know enough to know that I have to be really cautious when we start talking about competition.
So again.
Oh, no.
Your analogy of the person having a heart attack and ambulance takes them wherever they need to isn't impacted by competition, I think is somewhat flawed, because if the same entities all along that route that the ambulance is taken is owned by the same governing body or the same entity, there's not competition between whoever they may be. If all the hospitals are owned by one company, the chances are that those prices could be a little enhanced versus if they were each owned independently, the pressure would be to have less costs. So the chance that the person in the ambulance is going to be impacted at a lesser cost if they're owned separately is greater.
Madam Chairman, did we jump into a world where all the hospitals are owned by the same entity?
No, but I think the information that I've been reading over since last fall on a broad national basis is the consolidation of hospitals as a whole on a national basis, which in my part of the world has an impact, has indeed impacted that competition, might even cause a new hospital to be built.
Hypothetically. Yes. I also didn't touch on as much and probably should acknowledge that the role of private equity buying up physician practices is a significant one. I think thankfully we haven't seen as much of it here in our state yet. But goodness, when I go to national meetings, it's a pillar of the conversation topic among my colleagues in other states about the impact that private equity is having on healthcare and physician clinic practice. I was being a little facetious. I do think that it still stands that someone in an emergency isn't making a market choice. And I guess that's all I intended. And you were also, I'm sure, correct. In your analogy, I missed some of the part where we jumped into them all being consolidated. I think that basically concludes my presentation. I really appreciate the questions. I really welcome the conversation. And again, we'll stress that I hope that the physician community and our organization can be partners in all of this. I think everybody holds on to some things we know that we think we don't want to disclose too freely in the event that it hurts an ally. And I think the truth of it is Wyoming is such a small state and we have such a fragile infrastructure that we're all allies, and that casting aspersions, no matter where they go, doesn't help any of us. I will also say that the Medical Society has historically remained neutral on non-compete clause policy. I know, well, it's because we have a real diverse membership and they all have very strong feelings and they're all in slightly different situations, some employed and some employers, which makes this really tricky for us. So I will remain neutral. Thank you.
Mr. Bully.
Just as a point of clarification, as I listen to this conversation about, it's called facility fees in our clinics. It's not a very broadly used practice in most of our hospitals. Most of our clinics are actually rural health clinics or are run separate from the hospital, but there is some of that. There's also some work being done nationally, federally on that particular thing as well. There's quite a bit actually we haven't even discussed today about what's happening on a federal level to address some of the issues that we're talking about having to do with Medicare Advantage, prior authorizations, transparency, physician fees. There have been numerous hearings back in Congress, both from the payer side as well as from the hospital side to take a look at affordability. So we're a microcosm of what's happening nationally, but I just wanted to let you know that's not a very common practice. I'm only aware of maybe one or two hospitals that actually do the physician or the facility fee in their clinic.
Yeah, thank you. I guess I would say in response to that, I think it's what I meant about needing really good state-specific data. And many of you on the committee have heard me jump on this soapbox, so I'll be really brief. But I think when we did have a healthcare commission and we did have a centralized entity that could conduct or commission studies that were trusted, objective, and third party, it helped conversations like this one a lot because in fairness, I am pulling some data and it's coming from national sources because that's what's available to us. And so I don't know what the consolidation role has played in Wyoming's healthcare costs because we don't have that data. And so in complete fairness, it's entirely possible that it isn't a contributor in our state, but I think it's worth finding out. And I don't have the resources or expertise to do that. Thanks.
Yes. All right, thank you, Ms. Bush. All right, committee, we are almost done with our first meeting. Mr. Co-Chairman, any comments from you? I have some action items for us to consider, but curious to hear your thoughts.
Thank you, Madam Chairman and members of the task force. As we get ready to, and I think the action items are going to be really important. But what we had envisioned as we come into the second meeting, that we have this gap of time that we can come back and have ideas on how to resolve some of these problems. The Hospital Association submitted a document that has some suggestions on. I thought it was premature to go on. I just didn't want to take all of the time as we talk about these. I think the Department of Health, I think Department of Insurance, and we all may have ideas that have value that we need to look at this time. What I would hope, Madam Chairman, is that if you've got some of these ideas, I know that we have distances to travel today and obligations to meet, but if you would send, as you get something in your mind, if you would send these ideas to me and Chairman Nethercott, and then we'd like to start ferreting out some of those ideas with you so that we can kind of understand the structure of that conversation in our next meeting. So.
Mr. Co-Chairman, thank you. We can take some public comment now. And then we'll get back to our action items.
Good morning, Madam Chairman, members of the task force. My name is Rachel Bozis. I'm with the Natrona Collective Health Trust out of Casper. And given Mr. Boley's very in-depth discussion of uncompensated care earlier, I wanted to discuss how we're trying to address that in Casper. It does briefly touch on Title 25. But one of the things that we are working on, we have a coalition with that has more than 50 members, and that includes Banner Wyoming Medical Center, Central Wyoming Counseling Center, Wyoming Behavioral Institute, police, fire, the sheriff, and a lot of our nonprofit partners. And we are trying to reduce those uncompensated care costs by working with our most underserved population and our most at-risk populations. And so these are people with addiction, with mental health problems, usually are unhoused. They spend a lot of time in emergency rooms where they don't belong. They spend a lot of time in jail where they don't belong. These are huge costs, and these are really expensive items for people that are really, really unwell. And so we have a couple different data gathering initiatives that we're working on, the first of which we call it our most visible persons. We're working with WISAC out of the university to track our 30 to forest highest users of this system. And so we are identifying where they go, whether it's healthcare for the homeless, whether it's CAP-NC, do they need case management? Why were they at the ER? What happened when and if they were titled? And so we're tracking those 30 plus individuals to figure out where the costs are and how we can better serve them. Because these are huge expenses, not only to our hospital and our uncompensated care, but to our jails, to our sheriffs, response times. One of the initiatives that we're working with was with the municipal court. In 2025, it saved 3,126 jail days. And at $147 a day in jail, that amounted to nearly $500,000, $459,522. So these are savings that we're reducing from taxpayers, and we're also giving people the help and treatment that's so much better for them and long-term outcomes than just putting them in jail. The other data initiative we have is we are working with our healthcare for the homeless, our public health system, and a couple other entities to use software called Core Data. And what that does is it allows these different agencies to talk to each other about these people that still follows all of HIPAA and legal guidance and protects the patient's privacy. But it allows them to know where they've been at in these different systems. What gaps have occurred? Did they not go to this appointment? What did this agency recommend? How do they need to go to other places? And I mean, these are really big, complex problems. And so we're trying to figure out how We haven't talked very much about social determinants of health. Housing is healthcare. You can't be healthy and well without a place to live. And so that's included in this core data component. That's included in our MVP study. And so we're trying to find really holistic solutions for people who are really unwell and cost so many different systems a lot of time and money.
Well, thank you for the work you're doing there. Sounds like there'll be some meaningful data that we'll be able to get out of that study. So thank you very much. All right, any additional public comment? All right, seeing none, public comment is closed. All right, committee, we'll go back to our action items. There was a couple from my notes today. One is to go back just to review. I really hesitate to do this. Is the co-chairman and I will review the legislation that was amended 10 years ago to determine whether or not it will be on the agenda moving forward, allowing hospitals and counties to privately bill emergency detained individuals. My hesitation is it's going to open up the door to a conversation that this committee is not designed to do, which is a lot to do with the underserved population, county costs, emergency mental health services. That's not the committee's purpose. But it does go to some of the testimony we heard and what Director Johansson identified, which is reducing some of that uncompensated care and allowing for those patients who come in that have private pay insurance to have that insurance pay for that service. So we'll be evaluating that question in that limited, very, very limited scope of allowing for emergency detained patients who have private pay insurance in that rare occasion that they allow to be billed in the event that that's not occurring. Questions about that? I have, and this is up to the committee, but I would move for a bill draft to repeal the grandfather provision in the non-compete bill passed in 2025, Senate File 107.
Madam Chairman, just a question for my clarification, and you may have mentioned it before. Can this task force sponsor legislation, or is it a recommendation to a standing committee?
So we will sponsor legislation in our limited capacity of approving a work product to take to a standing committee for their adoption, and then they'll take it as their committee bill. But in order for them to do that, we don't take to them conceptual ideas. We take to them our approved work product. So we are, for our limited purposes, sponsoring legislation for another standing committee to adopt.
Similar to what we've done with the Vulnerable Adult Mental Health Task Force.
So for just how we will proceed in exercising our process, motion second to move for a bill draft. It's not the adoption of the bill, it's just for a bill draft so you can see what that looks like. It's been seconded by the co-chairman. All those in favor say aye. Aye. All those opposed say no. That was a robust vote. Thank you for exercising your ability to serve on a legislative committee on behalf of the people of Wyoming. Impressive. That motion has passed. There will be a bill draft at our next meeting. I know that there's a lot of discussion about the concept of the liquor division and this ability for the state to perhaps become a sole source buyer of healthcare products, for lack of a better term, and how that would work. And because that topic is so large and because we have only 2 meetings after this, to get some maybe further just general conceptual ideas so we can give direction to staff or ourselves as to how that may function. Do we want it to be researched? Do we want a bill draft? Do we want to require somebody in the room to provide a list of products, like knees, similar to that. Pharmaceuticals, that's maybe a whole nother category than medical devices. medical implants. So just want to hear some feedback. Commissioner Rude?
Madam Chair, I understand that Colorado just passed a bill involving 20 high-volume drugs just like this, like we're talking about, where the state would distribute them through Medicaid, and that might be something else I could pull up and take a look at. I recall something, I want to say 7 or 8 years ago, where the state of California and Oregon were moving towards doing that in a very large capacity, but I've not heard anything since. So it might just be a direction to look at.
I'd kind of like to get an idea. We've really been looking at talking about the hospitals, and Mr. Boley, if you and Kelsey could maybe get an idea of what those items might be. We focus on drugs, but are there any other items? But it would be helpful if we could sooner than later kind of get a list of things that we'd maybe consider. And then, Madam Chairman, I think we'd need to consider on what the structure of doing that would be, and maybe be ready to have that conversation and request a bill draft at the next meeting.
Yeah, so let's kind of conceptually continue to work through this because it's just 12/12. I mean, so we've got a little bit of time. So I'm shotgunning here, but I'm thinking we would direct the Department of Health to create a division that would be unfunded. We would fund it for the purpose of negotiating and purchasing these products, again, for lack of a better word. I suspect it's more complicated to do pharmaceuticals than devices. But I don't know. You know, and so it'd be the Department of Health responsible for negotiating, competitively purchasing those products, storing them, getting them in bulk, just like the liquor division does on behalf of all alcohol retailers in the state of Wyoming. For those of you that don't know, the state of Wyoming buys all liquor that you purchase in the state of Wyoming. They buy it from the outside source, and then every liquor retailer buys it at cost from the state of Wyoming. And so it's a very unique model, but it could help consolidate our buying power to help lower costs for our hospitals. So this would be an advantage to help increase profit margins by taking that burden off of them to negotiate with their vendors individually. And all of our hospitals are trying to negotiate individually, and other practice providers. And that there's a sole source that has been purchased much more competitively than they likely could get theoretically. And then that's provided at cost to the patients, and that theoretically would reduce healthcare costs. So I think we need is more furrowed brow from Mr. Boley and a list of those products that hospitals struggle with that provide. And I think our health insurance providers in the state could identify how much a knee replacement, the actual product itself, costs in maybe Cody as opposed to Cheyenne, and really kind of see some of those disparities in product costs. And so they can help us also provide a list potentially of those items that are notably expensive, increasing this premium cost. So at our next meeting, hopefully that our committee member, Mr. Red, can come forward with a list. Ms. Williams can come forward maybe with a list of those items. Hospital Association, anybody else want to get a list? Co-chairman?
Director Johansson, I have in my mind that within your agency now, you should do some of that, but this, am I wrong, or have we done that in the past where you've done some, or would this be plowing new ground for you guys?
Madam Chairman, Mr. Co-Chair, it depends. If you're meeting within the health department in our 5 facilities that we operate, this is a term everybody knows that operates healthcare facilities, group purchasing. And that's really the concept we're talking about, whether it's the state of Wyoming that does it or multiple entities coming together, improve their purchasing power, their buying power, and therefore get better unit prices. Spoiler alert for the Department of Health facilities, most GPOs or group purchasing organizations that we've talked to have laughed after a series of meetings and said, well, you're you have large facilities, but they're large for Wyoming, and we can't get you a better deal. Now, there's nuance there, but Mr. Boley can speak to GPOs as well. And I think that's one thing. In terms of the Department of Health having a new division that would be the liquor division of healthcare, that would definitely be plowing new ground and warrant quite a bit of study. But I think the concept is certainly makes sense, and happy to provide whatever assistance, research, analysis we can on that. Madam Chairman, if you'll allow me, and please feel free to cut me off because this I might bloviate a little bit, and this is Stefan struggling out loud somewhat, but I took your comments, Madam Chairman, to heart yesterday and today in tying this back to why this task force was established around health insurance and healthcare affordability. The genesis of it, I might be wrong, really stemming from recent changes in federal policy, but also state dynamics of the cost of healthcare driving consumer prices, largely around insurance, up substantially and significantly. So everything that we've presented on, that I've heard from others yesterday and today, a few examples, we've heard a lot about high fixed costs of certain things, basic services, emergency services, OB, EMS and ambulance, high acuity behavioral health care, trauma, stroke, imaging, et cetera, as one of those drivers. Regulatory burdens, electronic health records, reporting, claims and billing, liability, prior authorization, credentialing, provider enrollment, all kind of in that regulatory or administrative side being a driver of additional costs. Our population or consumer health status and our demographics, how we're aging and changing payer mixes, being drivers of additional costs. Consolidation today, another great, interesting, but also tough topic on how that economic structure of healthcare delivery is driving costs. And now apparently purchasing and giving the Department of Health a new function of buying all of the drugs and all of the knees and all of the hips, but the concept being there around purchasing power in a small state. Madam Chairman, all of those I think are worthy of study, worthy of this task force's attention. Where I think the struggle is, if you take those factors that we can either hypothesize may be driving costs, or in some cases can quantify these are driving costs, trying to tie that back to action that the state of Wyoming or legislature could take on if that were to change, if there were a mechanism, and we've talked about a lot of them, whether it's policy, law, finances, if we could influence one or all of those factors, does that translate, and how would that translate to our citizens? Healthcare costs, health insurance costs, healthcare costs more broadly, health insurance costs as a factor of those healthcare costs. That's a struggle. I would encourage everybody, if you have epiphanies on that, to share them with me on how you tie those things together, because we can agree, we can debate the merits of how impactful those things are. But I think that what I'm sensing as the driving force is, if we were to change one of those, can we be assured, or can we hope that that change would result in an X% reduction in our citizenry's health insurance costs? And I think I'm understanding that. I hope I'm understanding that correctly. And that's a real challenge that certainly from my personal perspective, I really need to noodle with and study and talk with my team of how we can help potentially come up with a framework for how to do that. But if I'm off base on that, please correct me, but that seems to be the fundamental issue that perhaps could inform our next meeting.
So no on the liquor division?
I'd say a hard maybe.
Okay. Co-chairman?
So from my perspective as in this task force, I think you're seeing that right, but I think some of these action items are the product of the conversation that's taken place over the last couple of days, identifying, and maybe to the co-chairman's notion that there is a bit of a pivot. While we identify these, isn't this the place to perhaps address them, the non-competitive agreements? Are there things that we can affect pricing, maybe not, may or may not really address the cost of health insurance, but if we sit here and identify opportunities to address costs, which I think I heard yesterday was one of the things that really has value, then why would we not try to address that? Why we have this group together? Coming back then and saying, but what could we offer the citizens of the state that would allow them to reduce the costs they're paying for health insurance or health care? I think it is the primary focus. And I think that we, as we go through these action items and as we come back and hear from each of you, I think that there's some ideas there. One of the ideas is that you and I have talked at length that I think has value is, can the state provide options as a non-insurance company to the citizens of the state in a package that at cost, similar to recommendations that the Department of Health made in the Rural Health Transformation Project. Can we take that concept and further refine it and make that an option that maybe not be full-blown health insurance with the 10 essential benefits being cost, but there may be many of these small businesses are saying, I can live without 10 essential benefits. I would just like to have an opportunity to have healthcare. So if that's something that we could consider, that then would, and to answer your question, would directly impact the citizens of the state, I think those are the considerations that we want to have and be ready to do, if that makes sense.
This would be my response to Director Johansson's comments, which would be an observational statement from a professional executive wanting to do something logically data-driven with a long-term plan. Welcome to the legislature, right? And being a legislator, where we have to move a little faster. We have 4 more days. 4 more days to provide health insurance affordability to the people of Wyoming. 4 days, right? We just burned through 2. So we have to move a little faster, and it is sausage, right? I mean, legislation is sausage making, and sometimes it feels that way, and it is a shotgun approach. The ideas we're talking about today, right, are just to get some action items started so we have a workable product at our next meeting, which we may or may not move forward. But ideally, yeah, I mean, this topic is an elephant, and we are taking very small bites at it, and that's all we're probably going to be able to do. With the exception of what I think a lot of people would like is a large financial appropriation. But what we're trying to do is reduce, and a liquor division, fundamentally reduce costs and understanding how to do that. So Director, what I heard you say is your team is going to go back with that directive in mind and identify how to do that. We're looking forward to that result. Yeah. Yeah, that's what I heard. So no, I mean, this is very difficult, and it's not sometimes, doesn't feel sometimes logical until you see it work for quite a while, but trust me, it'll work out. Mr. Boley?
So the furrowed brow, Madam Chairman, we've been working, just recently, we've been introduced to a vendor that's local in Albany County in Laramie. And we are pursuing an enhancement to our hospital GPOs where they can provide discounted supplies at a much cheaper rate that wouldn't interfere with the current GPOs that our hospital have, but might enhance those and give them either bargaining power or the ability to just buy cheaper. And so I'm a little hesitant to have the state take that on if we can handle it ourselves. But it's fairly new is what I'm trying to share with you. And we just had a couple of initial meetings with them.
Better yet, we don't need, Madam Chairman, it doesn't need to be that the state takes it on. We just like the concept of purchasing power and how does that look? So the idea is who does it doesn't matter, right?
Right.
We can report back to you on that. The only caveat is they don't provide pharmaceuticals, and that might be one of the areas that the state might have the bargaining power. I don't know, but we're looking more at supplies.
Representative Gallagher.
Thank you, Madam Chair. And I think from my standpoint, does it make sense? Are you already, or is there an opportunity to reach across state lines and expand that buying power with those GPOs? Can we have, is there something prohibiting you, or, is there something legislatively that we can do to enhance that ability to group up, say, with the Colorado market, which does provide that kind of buying power, or with some of the smaller states to say, Wyoming has a very small quantity, but when you expand across regionally, are there efforts that we can do to expand it that way? And is there something that would be holding you up either, do we need some sort of facilitation from state or even federal level to be able to do that?
Madam Chairman, Representative Garinger. So we have some of our hospitals that have affiliate agreements with out-of-state providers. So in particular, we have 3 that have an agreement with UC Health. They've actually got access to UC Health's bargaining power and benefit from that GPO. We have quite a few facilities that have affiliate agreements with Billings Clinic, and I don't know the answer, whether or not they're able to access Billing Clinic's GPO. I don't think there's really any barriers that, except just trying to find those partnerships. And so a couple of the concepts that we've discussed a little bit, and we covered a lot of ground, but there have been developments of what they're called high value networks. And basically it's pooling together. And we've been in contact with a couple of companies that want to help set them up, and they've set them up in other states, but they basically pool together, say 10 hospitals. And a lot of it has to come down with total net revenue, I think, or something. So that it takes critical mass to make it work. But we're exploring that and potentially putting that in place, which is over and above and separate from this vendor that we're aware of in Laramie that could enhance that. And so those are the things, as we waited for rural health transformation funding to come out and how the funding was going to be dispersed. Those are things we're going to be exploring. So I don't think that we have necessarily any barriers crossing state lines. I just think it's more of the partnership, trying to form those partnerships.
Senator Love.
Madam Chairman, thank you. As we think through all of these processes, I believe they're all worthy of studying, just like you mentioned. We really have to remember the focus, though, of what we're trying to accomplish, because in an industry that's largely subsidized by government funding, we need to find relief for the citizens in this. And it's not going to work if it just generates bottom dollar profits for providers. We have to put some of this money back in the people's pocket. And so I want to make sure that as we go through this, we're thinking of that and remembering that, because that's really the focus of our work here. So thank you.
Mr. Redd?
Madam Chairman, thank you. And I appreciate this conversation. I think the idea of a GPO is a great concept, and I understand the struggles that exist in this space as well. There are vendors, I think, and I probably shouldn't name their names, but I think there's some large vendors out there that provide services to hospital systems that could potentially be leveraged so that the Department of Health wouldn't have to bear the full burden of something like that. But potentially being able to know what those costs are and being to be a bit more transparent as what those costs are, I think could help drive down the overall cost that might be experienced through the system itself. And so a couple things that I just want to mention. I like the idea because I think it gets to the root of what we're talking about, bringing down overall cost of the healthcare. Is this the best idea? I don't know, but I think it is a good idea. Going back to reinsurance, which it sounds like I've been kiboshing this entire meeting, And I want to say that we are open to the idea of potentially a reinsurance program. And I only say that because it could lower premiums. And if that's the intent of this task force and committee, I just want to, I think what I've been trying to do is highlight that it may not lower the overall cost of healthcare. It could in the short term lower premiums. And if that's the intent of this committee, and it would be helpful to Blue Cross to be able to tell our members that we've found a way to lower your premiums and maybe it's only a short-term fix. And then the other discussion we've had is appropriating more money to spend on healthcare in order to solve the problem that we have here. And that doesn't seem to be a good solution either. So I say what I'm saying now because I see the GPO idea as addressing the exact concern that we're trying to address, which is to lower the cost of healthcare, and other ideas that may be similar that don't lower the overall cost. I'm not sure if this task force would want to adopt those, and that's me speaking as an individual because I don't know that they would fulfill the goal of the task force.
Thank you, Madam Chair. I'm not sure about the timing of this comment, but Senator Love's comments brought this back to mind. We spoke yesterday about the idea of increasing Medicaid, expanding Medicaid, and the knee-jerk reaction that is, look, there's a 90-10 match there. There's all that federal money that we could go grab. Well, federal money not only comes with strings, but is extremely inflationary, and that inflation is one of the main things that is driving the cost. So we end up chasing our tail. And so I guess I would just suggest that we try to avoid the easy way out and chasing federal dollars that ultimately are going to end up negating themselves in the future.
All right, I'm going to get us back to the liquor division. So I feel like there's consensus for a GPO concept that the state does. So what LSO needs to know and what the chairman need to know, what we need to help start creating is, what does that look like at our next meeting? What is the paper work product that we have in front of us that is the state GPO? And so please provide your thoughts about what the words on that paper look like for what the state GPO program is.
Madam Chair, 3 points. One, I'm going to guess that there would be something written up that I just want to make sure that the A&I procurement is not an issue with that.
Good call.
A&I. Second, if we have a drug division, if we have a drug division, is that the business we would be stockpiling that, having that inventory? How is that going to be provided to the hospitals and to Walmart's pharmacy or any of the pharmacies? One of the things that we contend with is the dispensing fees required. So just the logistical access of providing that. And I think a comment that was made just a few minutes ago was, even if the price cost goes down, unless that bill charge to the insurance is adequately adjusted as well, then to the point, it doesn't change the bottom dollar. I mean, when drug pharma changes their drug costs and reduces it, it doesn't necessarily save the state program any money because of the rebate game. So they lower the price of the drug, they lower the price of the rebate, so net we're still paying the same amount for the drug. So just I don't understand how that would entirely work. I mean, realize we'll flush it out, but we don't have Hoyes anymore, but how does Hoyes get an MS drug that they need through this drug division? So,
yeah, great question. My ill-informed instinct is that we don't start with pharmaceuticals. I think that's something we don't fully appreciate. And look for feedback from anybody who's paying attention about pharmaceuticals. But maybe for purposes of this, what I would direct LSO to do is to prepare a bill draft, creating a state group purchasing organization through the Department of Health, administered by the Department of Health, for the purpose of reducing the cost of medical devices such as implants, prosthetics, any other words anybody can come up with? Disposables. We'll Google some terms for those later. But that would be the bill draft to start, and I'm happy to work with LSO for additional feedback on what that will look like for our next meeting. Okay, with that, we're going to move from the liquor division and talk to some other ideas that I heard thrown out but weren't necessarily discussed further. One was bundle billing. And I think Mr. Boley mentioned that. And so, Mr. Boley, can you speak more thoroughly to that issue?
Well, Madam Chairman, I'm sure Mr. Red can also speak to this, but there have been attempts, and I think there's been some success where basically, let's take a total knee. If you do a total knee replacement for the patient, there's a set upon agreed price for the entire procedure from pre-op all the way through to post-op. And it seems to have some cost savings, and there seems to be some interest in some of our facilities wanting to enter into those agreements. I know for a fact that I sat in the meeting a couple of years ago. It was presented to it was before your time, but it was presented to the state employee plan, and there were some barriers that we were told that the TPA didn't have the ability to create that, or there was expense incurred. I think that's the same thing I've heard from other insurance companies. And so there may be expenses incurred to set up the system to allow that to go forward. But I think in the long run, over time, there might be potential savings there.
Madam Chairman, Mr. Boley, Blue Cross Blue Shield of Wyoming is interested in that type of construction, meaning bundled payments. And we have used that as a basis to lower cost overall by entering into bundled payment agreements with certain providers that can provide the care at a lower cost. And I think that that's an important thing that we as an insurance company have to keep in mind, is that the cost of care in Wyoming is high. So we have to find ways to find a location that could potentially provide the service at a lower cost. And bundling payments is a great way to do that. And if there's providers on balance, meaning a greater group of providers that be willing to enter into those types of agreements, I could see a lot of savings through a mechanism such as that.
Ms. Williams?
Madam Chair, I do have that information from the Aon study that was done several years back. I can certainly look into the data I have on what the stumbling blocks might have been at that point and whether or not those could be or are removed at this point, and report back and email the task force.
And so conceptually, again, should this be an action item, or is this just a fun topic to talk about or learn about? You know, should that be a legislative solution? Should there be a law concerning it? If so, would that be a stick or a carrot type situation where for providers who offer bundled billing?
How big is the carrot and how small is the stick?
Yeah, right. No, but I hesitate to require bundled billing from a legislative perspective, just because I don't understand how that might interfere with things I don't understand. But if it is a cost savings, then if there's a potential incentive of some sort. So I guess what I'd ask is for Mr. Boley, Mr. Red, Ms. Williams to think about that, recognizing that with my years of experience, there's some hesitation of requiring that type of practice for people's practices. Representative Larson?
As I thought about it and using the knee replacement, it seems to me that you have a pretty significant cost variation around the state per procedure. And so if you're going to do bundled billing, we're then going to establish what that price is per procedure? Or do we take their individual cost for knee replacements and say, we're going to pay you a cost, then you have to negotiate with each hospital to determine what that bundle payment is. So I'm like you, Madam Chairman, I'm a little hesitant to get into drafting legislation that Because I think that there's just a lot of variables that come into play there.
Madam Chairman, I'm not sure that I'm advocating to get into price setting by the legislature. I think that's probably the wrong place to go. But as we talk about conceptual ideas that can potentially drive down costs, I thought was an important one we talk about. And I don't.
But it would seem to be, Madam Chairman, that the ability to enter into an agreement with the hospital to do bundle payments exists now. Is that fair, Mr. Red?
Mr. Chairman, Madam Chairman, we do not do a lot of bundled payment agreements in the way that we're talking about with hospitals. And typically that's because some of the services that we provide bundled payments for are actually very expensive at the hospital. So we would look more towards an ASC or something that would take a bundled payment agreement. And I am speaking outside of my wheelhouse a little bit, so I know my testimony is being recorded as we speak, and I could have people cringing at the comments that I'm making. But what I will say is that we can come back, we can come back and explain this in further detail. I would say that when we talk about consolidation, when we talk about facility fees or site of service or that type of thing, there is a potential for the physicians to potentially be at the short end of the stick when we talk about a bundled payment arrangement.
Your legal education is manifesting itself. My question is there anything that would prohibit? There's nothing right now. You may not be doing it, but you're not prohibited from doing it.
Correct, Mr. Chairman.
Thank you.
I would like to note that there is a reasonable, healthy number of Juris Doctorates in the room, and I find that comforting. So thank you all of you JDs. We know who each other are. Not quite the doctors that should be in the room, but we're trying our best. So additional items that we talked about that you maybe would like to see moving forward that we could turn into a bill draft or have other information available at our next meeting. Co-chairman?
Madam Chairman, I alluded to the conversation Director Johansson and Franz and I have had on maybe providing a conceptual system that the state could participate in, allowing small businesses or families to have some coverage of healthcare at cost provided through the state. There's a lot of questions on that. So are we an insurance company? How do we do this? But I just say that conceptually, and we'll work with addressing those and making it clear what the challenges would be and what the options would be and how that looked. But I think it's something that would go directly to what the mission of this task force is finding a solution. So just conceptually would like to pursue that for the next meeting.
I support that, Mr. Co-Chair. I'm going to put a pin in this here for reinsurance. I think there's been consensus to have that topic move forward. Senator Crum, I know you've been waiting for a minute here.
That's fine, Madam Chair. That was one of my topics. I'd like to know more about reinsurance and kind of what Idaho did, and maybe others on reinsurance. I think that is definitely a possibility to help lower costs. Maybe it's only in the short term, but short term's better than no term. And then I'd like to learn maybe a little bit about how we would expand or create a program similar to either the Witchy or Wyoming program for like PAs and nurse practitioners, those type of things, and maybe even expand Wyoming where we could get more docs in. Because I am a believer of the basic economy thing, supply and demand. If we bring in more supply of healthcare professionals, we're going to lower. Maybe it's only incrementally lower, but we will lower costs and we'll provide better service. So I'd really like to learn more about the Witchy and Wyoming program, how we could maybe expand those and include or come up with a program similar to bring in nurse practitioners and physician assistants to help maybe with some of our shortfalls in our communities.
Okay, great. So I'm going to direct LSO to look at Idaho and Montana's reinsurance programs that they have underway there as a point of a guide for us to potentially adopt some of those concepts. And for those of you who know about that, that'd be great. Mr. Red?
Madam Chairman, if we could add Colorado to that as well, I think that would be good. They've experienced 24% premium decreases due to the way that they've set up their program. And I think that there's some reasons behind that that I won't go into great detail on, but I think it's important that we look at something like that as well.
Colorado, Idaho, and Montana? Ms. Williams?
Madam Chair, I just want to point out that as that's being investigated, what kinds or restrictions of that reinsurance it is. I know there's different levels that you can get because the state program has such a high reserve and the attempt to keep that. It's always been deemed that it's my personal opinion that it's inappropriate to use members' premium to pay premium for reinsurance when so long as we have that healthy reserve, that's an administrative cost we don't have to pay. And much like six accidents, it's going to continue to go up. I just had it was an article, but it came past my desk that a lot of those are about a 13% increase. So as far as the state program's concerned, I'm kind of adverse to them unless I'm really educated on why it would really save money long-term. So
Good to know. Thank you. And then Senator Crum just mentioned he wants more money for Whammy Witchy.
I don't know if it's fine.
So, Madam Chairman, perhaps we could just follow up on some efforts and report next time. Maybe Director Johansson, we could just report on the efforts we've had over the last couple of years in getting additional seats for family practice and whatnot at the University of Utah, and getting those seats in position and in other ways that we can use the rural health transformation for increasing capacity, or I forget the term you use, but that's really a great opportunity in adding workforce professional into the system, and maybe we could just get a better feel of how that looks.
Madam Chair.
Senator?
I think that's would be a great idea. I'd also really like to look at this nurse practitioner, physician assistant piece too. I'm not saying we're going to do it, but just what would it take to create something that would help those professionals get an education and then stay within the state of Wyoming, or at least start their careers in the state of Wyoming. What something like that would look like, not asking for a final product, but just what something like that would look like.
It's gonna be fine, Director Johansson. It's gonna be fine.
Madam Chairman, it absolutely is fine. And I think to Chairman Larson's comments, just a suggestion, we are implementing the rural health transformation funds for year one right now. Many of the topics we've talked about, there is funding that is going to make attempts to address some of these underlying issues with our critical access hospitals, EMS providers, workforce. There's boundaries around it, both federally and with what's in our approved, plan. But I think at our next meeting, at the very least, a very brief agenda item, we can report out on those things and also the connections to these concepts that we're discussing as a task force.
The only outstanding issue that I see, but it's pretty large, which is what Ms. Bush testified to, and we've identified, but we don't have the data, which is the consolidation of healthcare entities and then those providers within them. And so any thoughts from the other folks in the room about how we could get that data and understand that more thoughtfully? Representative Pendergraph.
Thank you, Madam Chairman. I have developed a relationship with the CEO there at Sheridan, and they just joined the Billings Clinic. And a lot of the things that we've discussed, my understanding is that's why they did it. Group purchasing options and other things. And I don't know, I think his actions are rather unique in Wyoming. He probably could speak more to that, but it might be good to hear from him as to how that worked and what the benefit was. And then while I have this thing on, I still would like to hear some sort of a framework explanation of how the cost sharing co-ops work for medical bills. Not really insurance, but how do they work? How do they survive? What do they leave out that insurance covers?
I made that assignment to Franz.
Yes, and that will be on our agenda next meeting, that particular topic. Okay, well, we'll think about that. About where to maybe get some more data for what I'm driving at is potentially antitrust, consolidation of a competitive marketplace by the constant practice of acquiring and selling health practices and how that affects premiums at the end of the day. Co-Chairman Larson?
I just have a question as we've talked about this reinsurance that maybe Director Johansson, you can help me with, or Commissioner Rude. It appears that those states that use reinsurance have been using 1332 waiver through the ACA, and they help pay for that with the premium tax credits. Is that's the source of covering the reinsurance? But with the premium tax credits largely being eliminated, did that impact those waivers? And maybe not the.
So I just want to make sure, I can't see the faces of most of our staff. Want to make sure that they heard Representative Larson's
That makes sense.
remark. We've instructed you previously to provide an overview of Colorado, Montana, and Idaho's reinsurance program. Sounds like they've been successful as a result of historical legislation that was just repealed in the big, beautiful bill. So what we'll want to focus this memo on is a brief overview of their success and any information we can glean from their plans moving forward, or if that's a viable plan as a result of the repeal of that in the big, beautiful bill.
Yeah, specifically did the removal of those premium tax credits then impact their ability to continue on with that reinsurance, which would then suggest that if we do reinsurance, that would probably have to be funded with general funds or some other mechanism.
Okay, I'm gonna stop us. Mr. Boley?
I'm sorry, on this consolidation issue, I'm trying to figure out, we're happy to help, but I'm trying to figure out what we're driving at. If we've had hospitals that have been approached by physician clinics to take them under their umbrella, that's not a hostile takeover. And so what would you like us to try and figure out for you?
Hostile from our perspective.
I don't,
Well,
yeah, Mr. Boley, I don't know that you need to figure it out. I think the question is, how could we learn the data that Ms. Bush identified? And so maybe Ms. Bush indicated that she would share those stats with us. We can understand the source of that data, see if they could look at that in Wyoming potentially, since they've got the skills to do that in other states. And we do want that to take place, right? We want practice clinics to be able to sell when they're ready to retire and do what they need to do. And that's part of the free marketplace, which helps competitive healthcare environment. However, there's a balance to that, right? And that relates to antitrust. And so are they creating these monopolies in these small communities that results in price fixing and results in other issues that does not create a competitive market, because we're very much prone to that in a rural environment, causing an increase in healthcare, as the stat that Ms. Bush provided of 11 to 17%, I think was the quote, which is alleged to have resulted in an increase in cost. I don't know if that's happening in Wyoming, but it would be good to get that data. You don't need to provide it, but ideas for how to get it, just because I don't know that you can determine that just from your membership potentially, because it's going to be all physician practice groups connected to hospitals and not connected to hospitals. So it's maybe something that we will not be able to deal with in 4 meetings, but would be helpful to think about. Mr. Redd?
Madam Chairman, thank you. I know we're wrapping this up, but I think as part of that discussion, and Ms. Bush probably rightly corrected me on the competition piece. I think maybe I was triggered by your antitrust comments, which those two terms go hand in hand if you're an attorney. But I think what maybe I'm thinking more along the lines of is a way to incentivize primary care in Wyoming, and whether or not some of the things that have occurred in Wyoming have disincentivized primary care in Wyoming, and if consolidation is one of those. But as part of that discussion, I mean, potentially, I think it would be important to wrap in a discussion of how we can incentivize primary care in the state of Wyoming.
Commissioner?
Madam Chair, so we'll forward to LSO a study that was done probably 6 years ago. We attempted a 1332 waiver, it failed. Then we received some grant funds from CMS, spent about $166,000 for a study over the year, because that's the first step. And so a new study would probably cost about $250,000. And we will share the conclusions at the time, which was, it doesn't work real well with Wyoming, but we'll share the whole report. And then we'll try to update it with some feedback from the states, because what we're hearing is with the new administration, the states aren't getting the pass-through cost savings they once thought they were. And there's some serious buyer's remorse here with the work involved in what they've done. So we'll share what we find with LSO and let them look at that as they look at these other states.
Thank you. All right, any final comments? Committee, I think we've done really good work these last 2 days. I want to thank my co-chairman for doing all the heavy lifting to get this agenda prepared, to talk with all the stakeholders that provided us such critical information. To the members of the public who've watched, it's very difficult to see a task force get created in its first meeting, a lot of big ideas discussed. It doesn't mean they're all going to move forward. We're part of that learning process to tackle this very big issue for the people of Wyoming, but we're on our way, so we appreciate all the feedback that we're receiving, your continued time and attention. Mr. Co-Chairman, any final words before everyone drives home safely?
Just an observation, it's just really fun to have the non-legislative task force members on this side of the dais and being able to really vocalize maybe some feelings that you would hold in reserve if you're sitting on the other side of the dais reporting to us. You're here because of our immense respect for you and what you do for the state, and have appreciated what you've brought to this meeting. And we to move anything forward, we really need your continued effort on this. So please accept our thanks.
A special thanks to LSO staff. That was a very difficult morning for us today with your directions. I do not envy your work ahead of us. Again, thank you. Everyone drive home safely. Meeting adjourned.